presentations are starting. And so I think it's 9:59. We're supposed to start at 10. So I think that's a good time to start letting folks in.
Okay, I just wanted to check if you're going to tell me when it's time to start.
Can I ask a quick question? Did the little timer work? Do you know?
Okay, great, thank you. Okay, hi everyone. Good morning, good evening, wherever you are. And welcome to our Thesis and Capstone presentations. My name is Keshet Ronan. I'm Associate Director of the MPH program in the Department of Global Health. And we're really excited to have you all here, our graduating students, their supporters, peers, family, and faculty members who really helped enable their work in the program. These presentations are a really exciting moment and milestone in their MPH degrees. This is the work that the students will be presenting is really the culmination of a lot of hard work over the last couple of years. So we're really excited to hear about all of your projects. Special thanks to Will Atienza, who organized these presentations and will be helping moderate today's session. Just a little bit about today's structure. Each student will have 10 minutes to present, followed by 5 minutes for audience Q&A. As you all saw, this session is recorded. Will has set up a little timer. So as you're presenting, you should see a little timer counting down. And then Will also be giving you a warning when you have, I think, 4 minutes and 2 minutes. So please keep your ear out for his announcements. If you're running out of time, please adjust accordingly so that you do stay within the 10 minutes. We have many presenters, and so we do need to stick to time. When the presentation ends, we really encourage audience participation. Anyone in the audience is welcome to ask a question, and you can do that either by putting a question in the chat box or raising your hand, and I will call on you to ask your question. And if we run out of time, presenters, please do answer any remaining questions publicly in the chat box so that everyone can read the responses. The last housekeeping note, please do keep yourself muted if you are not speaking. And we encourage videos on, but understand that people's bandwidth may not allow that. All right. With that, I think that is our housekeeping. So I think we can get started with our first presenter, who is Irene Myrie. Irene, are you able to share your screen?
Yes, let me just share.
I'm getting an echo. Could you speak again, Irene? Yeah, I'm still seeing an echo. Are you in the same room as someone, like Congo, maybe?
Yes.
Yeah, so if you can mute Congo's speaker.
Can you hear me?
Yeah, we still hear the echo. Congo, if you mute your speaker, I think what's happening is if your volume is on, it's coming back into Irene's microphone.
Are you still hearing the echo?
No, it's perfect. It's gone now. Thank you so much. Okay. Thank you, Irene. Please go ahead.
Can you hear me?
Yes, we hear you. Can you hear me?
Yes.
Okay, great. Go ahead.
Good morning, everyone. My name is Irene Myrie, and I'm going to present my thesis titled Exploring the Role of Social Support in Viral Suppression Among Adolescents and Young Adults Living with HIV in Homa Bay County, Kenya. For purposes of this presentation, I will refer to this population as adolescents. My positionality statement: I am a Kenyan with prior working experience in Homa Bay County. The study is based on primary data collection from a community that speaks my language. I did not participate in the data collection, but in the coding process as a secondary coder. Hence, my position did not influence the responses. Looking at the background of the study, we see that globally 1.7 million of young people ages 15 to 24 were living with HIV in 2020. In Kenya, this age group accounted for 40% of the national HIV prevalence, as well as new HIV infection in 2018. In Homa Bay County, where the study was based, is heavily burdened with HIV. The prevalence rate is 4 times the national rate of nearly 20%. While 92% of adolescents are virally suppressed nationally, only 86% are virally suppressed in Homa Bay. The study had 2 aims. 1, to evaluate key influences on social support seeking and utilization among adolescents with and without viral suppression, and aim 2, to explore barriers, facilitators, and strategies for improving social support for adolescents. The study used a conceptual framework. The framework builds upon the main effect model of Cohen and Wills to characterize informational, instrumental, emotional, and appraisal support. The purpose of the framework was to demonstrate how the large and stable networks interact with the 4 types of support to produce a positive impact on an adolescent viral load status. And informational support here is the provision of information and advice regarding HIV treatment and care. Instrumental support involves providing practical assistance, such as help with transportation, assistance with medication management, providing food. And emotional support expresses empathy, love, trust, and care. And appraisal support is the provision of feedback and validation that can help to boost self-esteem and promote self-efficacy. This was a qualitative study. In-depth interviews and focus group discussions were used. We utilized a purposive sampling to enroll 30 adolescents ages 15 to 24 to participate in IDIs. Additionally, we enrolled 18 parents or caregivers of adolescents and 18 healthcare providers who participated in focus group discussions. The parents and caregivers who participated in the FGDs were unrelated to the adolescent participants. 30 IDIs and 6 FGDs were conducted across 3 study sites. Study sites included 2 health facilities within fishing communities and 1 health facility from the mainland community to ensure diversity in the study settings. 2 qualitative researchers conducted interviews and FGDs in the Luo and English based on participants' preferences. Interviews and FGDs were audio recorded, transcribed, and back translated into English. This study used a card sorting, a participatory method that has been used in qualitative research. It actively involves participants in the decision-making process and encourages them to articulate the reasoning behind their choices. To help us understand this novel strategy to improve viral suppression and assess the direct influence of the 4 types of social support, card sorting was conducted during the interviews and FGDs. Participants sorted cards into 4 categories of who, what, when, and how. We used thematic analysis to identify, analyze, and interpret patterns of meanings from the data. The codebook was collaboratively developed with a priori codes generated deductively from the interview and FGD guides, and later refined inductively using the transcripts. Didu software was used for data management and analysis, and to ensure accuracy and enhance rigor, 2 coders independently coded all transcripts to achieve intercoder reliability. After coding, emerging themes were identified through analysis process. These allowed meaningful interpretations to emerge and facilitate a deeper understanding of the research topic. Characteristics of the participants: adolescents were median of 19 years of age, majority were females and single, 67% had a secondary level of education, 40% were virally suppressed, and we define viral suppression as having 20 copies per mil or less, and non-suppression as having 1,000 copies per mil or more. In the result, while comparing the preferences of social support options between high viral load and low viral load individuals, the card sorting revealed that regardless of viral load status, adolescents considered mothers, grandmothers, and healthcare providers as primary sources of support.
4 minutes.
And while based on the conceptual framework, adolescents emphasized the importance of receiving 3 types of social support: informational, instrumental, emotional, and emotional support for effectively managing the HIV. Based on the conceptual, regarding when they recognize the significance of consistent and stable support during all phases of HIV treatment for beta viral management, and in how the primary sources of support were regarded as important in providing practical assistance, emotional encouragement, and guidance on how to cope with HIV. And this is illustrated in the quote. I want support during routine follow-up ART treatment because the health providers are always monitoring my medication adherence and viral load. They are helping me to bring my viral load down. They call me and ask how I am managing my medication back at home and if I am taking the drugs as required. They encourage me and ask me about the challenges I'm going through at home, and that makes me feel good. In both groups of high viral load and low viral load, regardless of age, they all desired social support to effectively manage the HIV treatment. Whenever adolescents lacked sufficient provision of any of the 4 types of support, their viral load would increase. We also observed that challenges with accessing social support were spanning from the time adolescents were learning about their HIV status to ongoing phases of ART treatment and viral load monitoring. And this is illustrated by this quote: "My viral load rose again, and the provider invited me for a counseling session with my aunt. After that, my aunt started monitoring my adherence and viral load went down. Again, my aunt left me to monitor my adherence, claiming that I was now old enough to do it on my own. And so during this phase, I was struggling to know the right time to take pills, and even my viral load was bad because I couldn't observe my drug schedules." In the discussion, we see that similarities in preferred social support options suggest that viral load levels do not influence the kind of support adolescents may seek, whether suppressed or not.
1 minute 30.
Social support needs of adolescents are complex and varied. They require support that is continuous and dependable, and efforts to improve access to social support should be comprehensive and continuous in addressing the needs of adolescents, regardless of their age or the stage of their HIV treatment. The study had one limitation: achieving a perfect balance of adolescents with high viral load or low viral load was challenging. However, saturation of data was achieved. And in conclusion, we say that robust social support is crucial for adolescents, regardless of their viral suppression levels. Consistent and stable support throughout HIV treatment phases is critical for this population, and interventions should prioritize practical assistance, emotional encouragement, and guidance on coping with HIV. I'd like to acknowledge participants of the study, my mentors, IATP team, Cambridge CMR, and funders who, for this research and MPH studies, the Fogarty International Center, NIH, and the Go Health Fellowship Travel Fund. Asante sana.
Thank you,
welcome
Irene.
comments and questions.
Thank you, Irene, for that presentation. Really great to hear about your work and particularly in this important population. I have, oh, there are already questions in the chat, but I'm actually curious to ask my question, so I'm going to go ahead and use my prerogative to ask your question. My question is, did you hear from participants which forms of social support were already being received versus which were kind of unmet needs?
The 3 types of support that I mentioned, the informational, the instrumental, and the emotional support, they mentioned this because some of the adolescents were already receiving this support. So they were strengthening this, that if the primary support networks could continue providing these kinds of support.
Okay, so you didn't hear so much about like unmet support needs.
No.
Okay, got it. And there's a question from Awa. She asks, how did you select the parents and health providers, and were they associated with the adolescents?
I mentioned that the parents or caregivers who participated in the FTDs were unrelated to the adolescent participants. But how we collected them, we used the healthcare providers to identify for us these parents, because normally they accompany their adolescents to the clinics. So they could easily identify these parents or caregivers and refer them to the study team. So once they were referred, then we would request for their consent if they agreed to participate or not.
Thank you. We have time for another question. If anyone has any more questions, you can raise your hand or put it in the chat. No more questions?
I believe I had a question in the chat box.
Okay, could you read it? I'm not seeing it.
Yeah, sorry, I'm scrolling back. Ah, sorry, it was Awa.
Okay.
He asked, how do you select the parents and health providers?
Yeah,
Were they
we just addressed
associated
that
with
one.
I'm sorry.
Yeah. Okay, great. Well, if there are no further questions, I think we can move on to our next presenter. And our next presenter is Dismas Uma, who will be presenting on depressive symptoms, sexual risk behavior, and PrEP adherence. Congo, are you able to share your screen? And Congo was supported by his chair, Susan Graham, and his committee, Elizabeth Bukusi. And sorry, I just lost my screen.
Liz Harrington and Mariciana
And
Onono.
Mariciana Onono. Go ahead, Congo, the floor is yours.
Does Congo still have his speaker off? Can he hear us?
Yeah, can you hear us, Congo? Irene, maybe you could have Congo unmute his speaker. Congo, can you hear me?
Hello, can you hear me?
Yes, we can hear you very well. Can you hear me?
Can you hear me?
We hear you well. Can you hear us?
Can you hear me?
Yes, we hear you. Do you hear us?
Okay, yes, I can hear you. Sorry about that. I think
Okay, great. Okay, go ahead. We're ready for you to present. We see your slides, but they're not in present of you yet.
okay.
Perfect. All right, go ahead.
Welcome to my presentation, everyone from Kenya and here in Seattle and anywhere across the world. So my presentation is the evaluation of the relationship between depressive symptoms with HIV vulnerability and oral PrEP uptake and adherence among adolescent girls and young women in Western Kenya. For this discussion, HLW will refer to adolescent girls and young women, and PrEP will refer to oral pre-exposure prophylaxis. So my positionality, I was born and raised in Kenya. I'm a son, husband, and a father. And I had worked as a study physician for participants in this study. My role in this study was conceptualization, data collection, and analysis. Background: Sub-Saharan Africa has the highest number of adolescent girls and young women with unmet need of HIV prevention. This region, according to UNAIDS 2023 report, accounted for 82% of all new HIV infections among AGLW in 2022, with 2/3 of these occurring in Eastern and Southern Africa. Factors contributed to HIV acquisition among AGLW in Sub-Saharan Africa are complex, encompassing biological, psychological, interpersonal, and structural elements. This has been referred to as unique vulnerability in this region. Factors driving depression among AGLW in Sub-Saharan Africa mirror those contributing to HIV risk behavior, such as poverty, socioeconomic disadvantages, and limited social support. Understanding the burden of depression and its manifestation on PrEP uptake and adherence remains a critical need in this population. So the aim of this thesis was to estimate prevalence of moderate severe depressive symptoms, to examine the relationship between moderate to severe depressive symptoms and HIV vulnerability, and to determine the relationship between moderate severe depressive symptoms and oral PrEP uptake and adherence among AGLW. The overview of the parent study: Kenshi study is a double-blind, multi-site, prospective randomized study assessing efficacy of single-dose HPV vaccination against persistent high-risk HPV infections. It enrolled sexually active, HIV-negative, AGLW aged between 15 to 20 years in Kisumu, Thika, and Nairobi cities in Kenya between 2018 and 2019. At every contact with participants, the study offers participants comprehensive reproductive health services, including STI screening and treatment, HIV prevention, counseling and testing, and contraceptive counseling as part of standard care. We conducted a cross-section survey of 300 AGLW enrolled in Kenshi study between November 2023 and February 2024. After obtaining ethical approvals, inclusion criteria were girls enrolled in Kenshi study aged between 18 to 24 years, willing to give consent, and had to be HIV negative. We exclude those who are within 42 days postpartum or those who are known to suffer from any mental illness. Socio-demographic variables we collected were age, marital status, level of education, parity, income, and being in school. We used validated patient health questionnaire 9, adolescent version, to assess AGLW depressive symptoms over the last 2 weeks. Each of the 9 questions received a score of 0, not at all, to 3, nearly every day. A composite score of 0 to 27 was calculated. A score of 10 or more was regarded as having moderate severe depressive symptoms. HIV vulnerability factors we collected using standardized tool from the Ministry of Health to determine eligibility for PrEP initiation. This tool assesses the number of sexual partners, age of sexual partners, awareness of partners' HIV status, condom use, recent diagnosis or symptoms of STIs, use of post-exposure prophylaxis, again it was actual sex, intimate partner violence. To assess self-perceived risk for HIV acquisition, we asked participants, right now, would you say your risk of getting HIV is? The possible responses were low, medium, or high, or unsure. We extracted self-reported oral PrEP uptake and adherence from Kenshi study database. The oral PrEP uptake was defined as taking PrEP since the last scheduled Kenshi study visit, regardless of the source of PrEP, while adherence was defined as taking oral PrEP in at least 5 days of the preceding 7 days. Data management and manipulations were done in R. We analyzed data using descriptive statistics and exploratory logistic regression. We use Fisher's exact text to examine the relationship between moderate severe depressive symptoms and oral PrEP adherence. Sampling frame: we surveyed 300 AGLW out of about 1,200 participants enrolled in Kenshi study. 58 of them reported having taken oral PrEP since their last visit, and 12 met a definition of oral PrEP adherence. Results: the median age of 21 years, the majority had attained at least high school education and had ever been pregnant. Prevalence of moderate severe depressive symptoms of 14.3% with 95% confidence interval of 10.05 to 18.8, and did not differ with age as shown on the right. 2/3 of participants surveyed reported feeling depressed or sad most of the day in the past 12 months, and 16% of them reported having suicidal ideation or thoughts of self-harm. Self-reported HIV risk perception differed by depressive symptom status. A large proportion of participants with medium HIV risk perception had moderate severe depressive symptoms. In multivariable exploratory analysis, age or double who perceived their risk to be medium had an adjusted odds ratio of 3.23 and 95% confidence interval of 1.29 to 8.25, having moderate severe depressive symptoms compared to those who did not know their risk. Similarly, age or double who report engaging in transactional sex compared to those who had been pregnant once compared to those who had never been pregnant, and those who complete post-primary education compared to those who did not had increased odds of having moderate severe depressive symptoms. About a fifth of our participants reported oral PrEP uptake. 43% of them were adherent. Having moderate severe depressive symptoms did not predict oral PrEP uptake. An adjusted odds ratio of 1.2 and adjusted odds ratio of 1.01, 95% confidence interval both adjusted and unadjusted estimates cross the null. Prevalence of moderate severe depressive symptoms was lower in the group adherent to PrEP compared to non-adherent group. However, this difference was not significant, 8% versus 18.2% with a Fisher's exact p-value of 0.44. Discussion. Our study finding demonstrate a high prevalence of moderate severe depressive symptoms and suicidal or self-harm ideation among AGW in southwestern Kenya. Participants who reported suicidal ideation were offered psychological support on site. Factors that were associated with moderate severe depressive symptoms in our analysis were medium HIV risk perception, post-secondary education, transactional sex, and ever being pregnant once. Depressive symptoms were not associated with oral PrEP use and PrEP adherence. Conclusion, the strength of this study we were able to use validated tools and to collect complete data. However, we had limitations. We could not establish temporality by the design of the study. Only a small fraction of participants were taking PrEP, and we did not use standard definition of PrEP adherence. We recommend a larger longitudinal studies to assess the effect of depression on PrEP use, and posit that HIV prevention programs can be platform for integrating mental health assessment and support for AGW seeking reproductive health services, including PrEP. Acknowledgement. I want to acknowledge, I'm sincerely grateful to my thesis committee led by Professor Susan Graham from the Department of Global Health, and members Dr. Marciano Nono and Elizabeth Bukusi from Cambridge, Dr. Elizabeth Harrington from UW Medicine, study participants without whom this work could not have been done, colleagues at Cambridge Kisumu, students, faculty, and staff in the Department of Global Health, RTP family led by Professor Kari Fakwa, and everyone else who has joined this meeting. Finally, this research and my thesis studies were supported through a grant from the Fogat International Center, National Institute of Health. And I received funding, travel fund from Global Mental Health Travel Award 2020-2024. Thank you.
Thank you, Congo. Great work. Really nice to hear about it. As we await questions to come into the chat, I was surprised to not see any association between depression symptoms and adherence. And so I'm wondering if you could share a little bit about how this compares with the literature on that association. Is this consistent with what other studies have found? And if not, what you think might explain some of the differences?
So based on the literature that has been done, so most of it has been done in the longitudinal HIV prevention studies. But my take-home message from this is that the participants in this study, or AGIW in Sub-Saharan Africa, it's true they're battling with mental health issues, including depression. But in the hierarchy of needs or what they need, they just need support. And this might not, their worry mostly will not be what issue is, it may not be urgency to prevent, to getting prevention against HIV, but they're battling other things, which are just as I said earlier, social support, unfulfilled aspirations, not being able to go to school. But when you go to the literature, some other literature have shown that there's no any relationship, while others have shown that those who are depressed who are more likely to not adhere, while others have shown the reverse. Those who are saying not adhere, they are saying if someone is depressed, may interfere their urge or their need, their sexual urges, and they may feel they're not at risk. While at the same time, those who say that there's no, it's related, they say that it's a form of support.
Got it. Thank you. Let's see. I think we have one question in the chat, and then I'll go to Liz. The question is, how did you measure PrEP adherence in the study?
So we use self-reported data, and we define PrEP adherence as taking PrEP. If you are taking PrEP, if you're taken for at least 5 days in the preceding 7 days. So that's the working definition we use, which has also been used in literature elsewhere. But we know the standard definition will be doing pharmacokinetic testing. And since the design of the parent study was the offering PrEP as part of standard care, we just leverage it on it. But I think we can get a better definition. Just that the way we designed this, we want to just see if this participant had taken PrEP consistently in the past 7 days.
Thank you. Liz had her hand up, but it seems like maybe the question was answered. Any other questions?
Oh, I still have a question. Sorry, I just lowered my hand.
Oh, go for it.
Congratulations, Congo, on an excellent presentation. And of course, I've seen this data before, but I was curious if you had any perspectives on sort of the association with ever having been pregnant, and if that finding has sparked any, other research questions or thoughts about how that might be related to depressive symptoms.
Yeah, so just out of curiosity and experience, so I have a disclaimer. I think we just exclude those who are within 42 days of delivery, and yet we know if someone had postpartum depression can last even longer than 1 year and beyond. The other time is that the source of the pregnancy and social issue around the pregnancy in this population. So some of this pregnancy, some of these girls get pregnant, and it's a whole commotion. Maybe the boyfriend or whoever is responsible denies. They don't get a lot of support at home. It comes with the interruption of their education because of the fears and worries that accompany it. And so those are my thoughts around that.
All right, thank you. I think we're at time. Thank you again, Congo, for a great presentation.
Thank you.
All right, our next presenter is Keely French, who will be presenting on quality of HIV services for people who inject drugs in Pwani and Tanga regions of Tanzania. Keely's chair is Kate Wilson, and her committee is Pam Kohler and Eva Matiko. You see your slides, Keely, so you can go ahead.
Okie dokie. Can everyone hear me and see my beautiful
Yes.
shining face? Cool.
We see and hear you. Thank you.
Hi, everyone. My name is Keely. I'm going to be presenting my thesis titled Quality of HIV Services for People Who Inject Drugs in Pwani and Tanga regions of Tanzania. My thesis committee was Kate Wilson, Pam Kohler, and Eva Matiko. Yeah, I would just like to acknowledge certain aspects of my identity which help shape my understanding and delivery of this thesis. I was born, raised, and educated in the United States. I'm not an employee of ITEC, but ITEC does live within the Department of Global Health, of which I am affiliated with. My background is in public health, and I do have experience working with people who use and inject drugs in the US context. My involvement in this project was a quantitative analysis and manuscript writing. So as of 2023, Tanzania is very close to reaching the UN AIDS 95-95-95 goals. There are roughly 36,000 people who inject drugs in Tanzania, and acquiring HIV is 35 times higher for those who inject drugs. Within Tanzania, the HIV prevalence among PWID is 36%, compared to 4.5% of the general adult population. There have been recent advances to establish why retention and care and long-term outcomes for PWID are lagging, but there's limited research or long-term follow-up in the Tanzanian literature. There are also important evidence-based approaches to reduce opioid use disorder, medication-assisted therapy, or MAT. It's been shown to decrease morbidity, mortality, and improve the overall quality of life of drug users, and it is an essential component in addressing HIV care for PWID, both in Tanzania, Sub-Saharan Africa, and on the global landscape. And last but not least, the Tanzanian Health Promotion Support, or THPS, is the implementing partner of a 5-year program called the Afya Hatua program. THPS supports comprehensive facility and community-based HIV prevention, care, and treatment. So my role in this project was based under the ITEC project evaluation umbrella. We were curious to determine how the Afya Hatua program was doing in regards to HIV care for PWID. And since the Afya Hatua program was already operating in 3 of the 11 MAT facilities in Tanzania, it provided another way to improve the quality of the Afya Hatua program that ITEC was already conducting. And so the aims of this project were to describe the facility characteristics and service recipients of MAT care and their care outcomes within the facilities. And then secondly, to analyze the quality of those services using clinic observations at the 3 facilities and the variation of quality scores based on client demographics. So this project used a cross-sectional design using secondary data from a multi-year program evaluation. The data I used included 3 facility surveys, 102 MAT observational checklist, and routine data collected between October of 2021 and March of 2024. The inclusion criteria was restricted to facilities with active MAT services. Eligible providers and recipients of care were 18 years of older, provided verbal consent and received care, or were employed at the facility that day. The quantitative analysis included 4 parts: a descriptive statistics of facility characteristics, quality scores from the MAT checklist, which were used to measure the quality of the provider's skills. And third, a generalized linear model to determine if there was an association between the 2 age groups and their quality score. And then lastly, a descriptive time trend analysis for the routine data. Alrighty, so this slide shows the results from the MAT observational checklist. All data was collected between in July, August, and December of 2023. You can see in the box at the top left the client characteristics. There were 29 young adults between the ages of 20 and 24, and 73 adults over the age of 25. There was some gender data missing, so of the available gender data, we identified 70 male participants and 10 female participants. And then within the population, there was around 67% identified as PWID, and 28 participants were adults from other key and vulnerable populations. And then the tables on the right show examples of interpersonal and technical tasks which were observed. The technical tasks were based on national HIV guidelines, and the interpersonal tasks were based on interpersonal skills assessment and other similar studies measuring quality of care delivered. The tasks were observed by a data collector and then rated as done, not done, needs improvement, or in some cases non-applicable. And then each of these ratings have a numeric score to determine their quality score. This shows the breakdown of quality score results from the MAT checklist that I just described in the prior slide, which was aim number 2 of this project. So overall, between the 3 facilities, the overall score was 91.7. Interpersonal was the same, and technical was marginally higher at 91.8. There was limited variation between males and females, but interestingly, young adults had higher scores than adults 25 and over. In our linear regression, the younger age group was associated with a 3.1 unit change in quality score, but it was not statistically significant. And lastly, moving on to the routine data that THPS reports. The 2 graphs on the right are from the 2 clinics in Puwani, who have 2 full years of data, whereas the clinic in Tonga just began collecting data in October of last year, so we only have 2 quarters of data.
3 minutes.
Thanks. Of all of the clinics show a quarterly increase in enrollment at the facility. For Tumbi at the top right, that number was an average of 33.1 new enrollments per quarter. Bagamoyo at the bottom right had an average of 45.9. However, defaulting on direct observed treatment, or DOT, averages at about 29% for all 3 facilities. And so for Tumbi, that was 26.5, Bagamoyo was 25.8, and Tonga was 34.8. In the dark gray color, in most of the graphs, you can see graduation rate from the MAT programs. Alrighty, and now some takeaways from this project. In measuring the quality of care, which was aim number 2 of this project, the providers provided overall high scores, both by interpersonal and technical and by client groups. However, my recommendation for the implementing partner would be either trainings or refreshers of this guideline, either through focus trainings or mentoring. Additionally, prioritizing quality improvement and further research into the reasons behind defaulting and retention in care by PWID is needed. This could be through increasing MAT treatment to other PWIDs not currently enrolled, and thereby decreasing the gap in HIV care cascade by PWID to ensure that the UNAIDS 95-95-95 goals will be reached by even the most marginalized and vulnerable populations in Tanzania. And then lastly, as I just alluded to, the PWID are a high needs group. So incorporating more person-centered care, harm reduction approaches to HIV care would reduce the barriers to care not only within the Afya Hatua program, within the Tanzanian healthcare system and sub-Saharan Africa overall. These include, but are not limited to, low threshold services, flexible facility hours and service delivery, psychosocial and mental health support, and greater involvement of peer and community-based involvement for community awareness campaigns. And like a lot of my colleagues, I just want to acknowledge the hardworking people that were involved in my project. This included ITech Tanzania and their technical team and THPS team members. Thank you.
Thank you, Keely. That was a really nice presentation and Thanks for sharing about this important work. While we wait for people to raise their hands or put questions in the chat, I can get us started with the first question. Those quality scores were very high. And I'm just curious kind of what the source was for the checklist and what your sense is about the sensitivity and, you know, the performance of those checklists, and to what extent you think those high scores were kind of reflective of the quality of care.
Yeah, so I guess to back up, the checklists were from, I did not create the checklist. Those were from ITech Tanzania. So there was 10 interpersonal questions that I said were based on the, there's a interpersonal skills checklist, and then 29 of them were based on the national HIV guidelines. So there was definitely some variability between like, between facilities and between genders, but overall, it seemed like providers were delivering quality care. There was definitely some outliers, but overall, everyone was following the guidelines. But in terms of why there were high numbers, I think that this program has been running for at least 3 years, but so I think there's room for improvement, but I believe that providers are providing quality care regardless if they're PWID or not.
That's great. I see a hand raised. Go ahead, Kate.
Thank you, Kesha. Congratulations, Keely. I had 2 questions. One is one is about process, and then one is about next steps. So regarding process, I wanted to hear a bit more about how you engaged with THPS and ITech in this thesis experience to come up with your project and share back your results.
Yeah, well, I can direct that back to you. So thanks for being my chair for this project, and also reaching out. So how I got involved in this project, and specifically for looking at MAT outcomes for PWID, was just looking at like the overall Afya program and noticing that they were involved in 3 of the 11 clinics. So that's roughly 27% of all clinics in Tanzania, and it is a highly vulnerable group. So just understanding that the prevalence of HIV in that group is so high, and needing to know why that particular group was not either engaging in care or not staying in care seemed like a great way of enhancing the overall program evaluation of THPS. And to your first question, I believe, how did I engage THPS? I haven't looked yet, but I believe that Dr. Ava is on this call, and she is the director of programming at THPS. So it is my hope, and she has been actively engaged in this entire process, is that once I deliver my manuscript in a few weeks, that this information can be disseminated within the facilities and with THPS leadership in order to enhance the next 2 years of this program evaluation.
My second question actually was, what do you see as a follow-on research study or program implementation? What would be a next step from this project? You have mostly descriptive data, some nice quality scores showing high quality, and then still some gaps in retention and care in MAT programs. Maybe say more about what could be a potential next research question you could pursue in collaboration with THPS.
Yeah, great question. I think that in discussion with the technical team with ITech Tanzania and also with THPS affiliates, that understanding that the retention, especially for young adults, could lead to a more targeted research question on the reasons behind retention and reasons behind drop off of enrollment. So kind of creating a larger hypothesis about targeted interventions in the future within the Tanzanian landscape.
Thanks.
Thanks.
Thank you, Keely. I do see one more question, and we have 43 seconds. So if it's a very quick response, maybe we can try. Mbala says, I worked with this population earlier, and I was wondering whether these differences in facilities were region specific.
I think it's kind of hard to make comparisons. Thanks for your question, Mbala. I think it's hard to draw differences because it's one facility within regions with millions of people. There were differences in facilities between like younger adults and adults, but those numbers were lower than 10, like 10 clients that received lower care. So it's kind of hard to draw statistical differences, but we can chat offline if you are interested.
Thank you. Thanks, Keely. All right, we're out of time, so we will move on to our next presenter, who is Stanley Ndwiga. Stanley, are you here? Great. Okay. The title of Stanley's thesis is Determinants of Viral Suppression to Undetectable Levels Among a Cohort of Adolescents and Youth aged 15 to 24. This committee is chaired by Kenneth Mugwanya and includes Nelly Mugo and Kenneth Ngure. Take it away, Stanley. You're not yet in full slide view. Now you are. Perfect. We can't hear you if you're speaking.
So, thank you, Richard. Good morning, everyone, and thank you. I'm going to present to you my work. My thesis title of the study was Determinants of Viral Suppression to Undetectable Levels Among a Cohort of Kenyan Adolescents and Youths aged 15 to 24 years. So this is my positionality, born and raised in Kenya, a practicing medical officer, research scientist. The role of the study I was involved in primary data collection, analysis, and was also a study physician. Globally, in 2022, 4,000 adolescents and young women were infected with HIV every week. More than 75% came from Africa. Despite this advancement in HIV care, these adolescents often struggle with adherence with poor outcome. They struggle with psychosocial issues and knowledge gaps. Study aims. Overall study aims, we evaluated effect of psychosocial factors on viral suppression. The specific aims were aim1, we looked at the burden, we determined burden and association of psychosocial factors on viral suppression. aim2, we characterized trends of mental health status, treatment behaviors, impact of intervention, and treatment outcomes. Overview of the parent study. This study was nested within an ongoing study, which was a longitudinal cohort study, which assessed response and effectiveness of Gardasil 9 years post-vaccination. In this study, in this cohort, there was a 6-month follow-up at HIV standard care consistent of mental health screening using PHQ-9, and depending on severity of depression, intervention package of psychosocial counseling and referrals was used. Adherence counseling was offered for detectable viral load and poor adherence. Viral load was done at baseline and month 12. In this study, viral suppression was defined as less than 200 copies per ml. Study population. The study population consisted of 158 participants enrolled into the parent study. and who consented. And enrollment also depended on data availability at the 2 time points, that is baseline and month 12. And we enrolled 146 participants. Methods and outcomes. We used 2 complementary study designs. We determined burden and association of psychosocial factors using cross-sectional design and retrospective cohort to understand effect of intervention on adherence, mental health, and treatment outcomes. For method still, we abstracted data on M2, including file load results, PHQ-9 scores, interventions done from baseline to month 12. We use validated tools to aim for M1, which included PHQ-9 and a score of 5 and above indicated presence of depressive symptoms. We used HIV stigma scale and a score of 25 and above indicated high levels perceived stigma. A multi-dimensional scale of social support was also used, and a score of 29 and below indicated low levels of perceived social support. Alcohol use disorder identification test. We used that, and a score of 8 and above indicated harmful alcohol use. Data analysis. The primary outcome was file suppression. Social demographic characteristics were summarized by medians and ages for continuous and frequencies, and percentage for categorical variables. Covariates included depression, stigma, social support, and alcohol. A modified Poisson model was used to determine association. Result, general characteristics. The median age was 22 years. Females were slightly higher. The proportion was 51.4%. Recent file load suppression was 81.5%. Prevalence of depression was 14.4%. Stigma was 58%. Prevalence of low social support was 1.4%. And harmful drinking preference was 7.5%.
About 4 minutes.
Association. Overall, the prevalence of HIV-related stigma and perceived high social support were high. The prevalence of low social support was low, as well as depression and hazardous alcohol use. Overall, we did not find any association of these factors with file suppression. This graph shows trends of proportion of key outcomes at baseline and month 12. High proportion received interventions were file suppressed at missed pills at month 12 compared to baseline. Less proportion had depressive symptoms compared to baseline. So in discussion, this study found high stigma, low depressive symptoms, and low harmful use of alcohol, but high levels of perceived social support was reported. Overall, majority achieved file suppression, but did not find association between us and file suppression. The strength and limitation. This study provided insightful information about the psychological variables affecting file suppression. Major limitation in this study was sample size, as well as both recall and social desirability bias and lack of qualitative interview to give us more insight. Conclusion. Need to apply larger studies to assess these factors and effect of interventions. A qualitative study would give more depth and insight.
2 minutes.
I would like to acknowledge all study participants, my thesis committee and mentors, Drs. Kenneth Mugwanya, Neri Mugo, and Kenneth Ngura, PHLD Thika staff are well appreciated. My lovely family, ALTP tutors, and ALTP staff. This study at my MPH studies were supported through a grant from Fogarty International, National Institute of Health, Women and HIV. I'd also like to appreciate the Global Opportunities Health Fellowship, which also supported me in this study. Thank you, asante sana.
Thank you, Stanley. Thanks for sharing that nice presentation. I will encourage the audience to ask questions. And while we wait, maybe I can ask you kind of what's next for this project, for the parent project, and also for your work.
Thank you, Kachet. I think I would like to explore more and maybe explain why we found an association in this and the relationship between psychosocial factors and viral suppression. Yet, okay, major other publications have found some association. So after manuscript, I think I would want to go back and really do maybe a qualitative aspect to find out what really could be happening. Maybe these people, some of them are experiencing high stigma, yet we find there are no association. We also found a notable suppression levels, though we have not reached that level of 95. That was 81.5%. So I think there's something we can explore more.
Yeah, that makes a lot of sense. Other questions from the audience? Steve, go ahead.
Hi, Stanley. Very nice presentation. I was surprised that there was not more of an association between the psychosocial factors, and obviously it had a lot to do with the fact that you had a high level of viral suppression. I was interested that you had 12 people. The sample size wasn't big, and 12 people did not enroll in your sample. Do you have any information about those 12 people? Because I can imagine that it might be psychosocial factors and or viral suppression might have affected their enrollment.
So thank you, Steve. And we looked for these participants. Some of them, we called them, some have relocated outside the country, so they could not make it due to distance. Allowed 4 of them said they were not, due to work schedule, they could not make it to come for appointments. Then 3 of them were not interested in participating. So that's why we could not get all of them to participate. Thank you.
Thank you.
Any more questions for Stanley? All right. Well, thanks, everyone.
No question, but I just really wanted to commend Stanley for this work. It's never easy to do a primary data collection at a master's level, which involves actually a new application for an IRB. So I think that's a tremendous learning opportunity, regardless of what the result is actually. Yeah. Thanks so much, sir.
Yes, agree. Kenneth, we learn so much from every study we do, regardless of the findings. Thanks, Stanley. Congratulations.
Thank you all.
Okay.
Appreciate.
All right. We will move on to our next presenter, who is Amanda Lee. And the title of Amanda's presentation is Facilitators and Barriers of Telehealth Access Among Asian American Elderly and Immigrant Populations in King County, Washington. Her committee is Dr. Jane Lee and Dr. Diem Nguyen. Go ahead, Amanda.
Thank you, and good morning, everyone. Thank you for joining us. So I'm presenting today on facilitators and barriers of telehealth access among Asian American elderly and immigrant populations in King County. This is a qualitative capstone project from a community-based organization perspective. And thank you so much to my committee members, Jane and DM. A little bit of an overview of my talk today. I want to start off with a positionality. I see myself as both an insider and outsider to this work. Identify as Asian American. However, I was born in the US, and so I don't have that lived experience as an immigrant. I'm college educated, and I do come from positions of power with my affiliation with the University of Washington, as well as with the organization that I did this capstone project with, which is the Pacific Hospital Preservation and Development Authority, or PHPDA. A little bit of background on the project as well as the organization. PHPDA is a grant-making organization that works towards health equity by making grants to organizations committed to increasing healthcare access for marginalized populations and decreasing systemic inequities. For my project, I submitted a proposal to PHPDA's Health Equity Scholar Program that works with students to connect to their grantees and dive deeper into specific projects to inform PHPDA's grant-making priorities. This project was aimed to address PHPDA's priority in 2023 on technology specifically. This project was accepted, and I worked with PHPDA to hone in and finalize this project. I connected with UW faculty members to leverage this internship into my MPH capstone project, and I received a IRB exemption in September of 2023. A bit of background on this health issue more broadly. During the COVID-19 pandemic, we saw a lot of inequities in healthcare access that limited access to healthcare services. This particularly impacted people who primarily accessed healthcare in person. And one of these populations is the elderly and immigrant Asian American population. A possible solution to this was the use of telehealth. However, there were structural barriers that deterred the widespread access of telehealth within this population. A couple of these reasons was a rise in anti-Asian rhetoric and violence during this time, language barriers, and a lack of digital literacy and device access among this population. So this leads me to my project question, which was looking at the facilitators and barriers to implementation of telehealth programs from a community-based organization or CBO perspective. This then leads into the conclusion, which is recommendations for PHPDA that come out of these results to improve their grant-making priorities within this population. Taking a look at my method section, this began with a formative stage, which was reviewing PHPDA grantee reports. These were both in quarterly and end of project reports. These provided a lot of background details on the telehealth programs that the CBOs were implementing during this time, as well as just their overall missions and objectives. This process also informed a priori interview guide development that led into semi-structured in-depth interviews. I had 5 CBOs represented in my population, and these were the Asian Counseling and Referral Service, the Chinese Information and Service Center, the International Community Health Services, Mary's Place, and Washington Telehealth Collaborative. The collaborative was actually not a grantee of PHPDA. They work more broadly across Washington state to connect people with resources related to telehealth. And so I included them in this study because I felt that their perspective was valuable in this type of project. I then conducted thematic analysis where I inductively developed codes through developing analytic summaries and open concept coding. The interviews were audio recorded and transcribed and then uploaded to Atlas TI, where I did more formal qualitative analysis. This resulted in 9 code categories and 34 codes. Diving into my results, I had 4 themes that came out of these interviews. The first was that limited availability of COVID-19 and telehealth related resources in participant native languages was a barrier to telehealth uptake. This is a bit of an intuitive result and makes sense with previous literature as well. If you don't have the resources in your native languages, it's going to be a lot more difficult to access new resources like telehealth. My second theme was that technological access was a major barrier to client adoption of telehealth, but this could be addressed with a focus on capacity building. And so this was particularly talking about access to devices and network connectivity, but it also had to do with digital literacy and knowing how to navigate telehealth platforms. However, participants did recognize that by focusing on capacity building or developing those skills within their patient populations was very impactful in increasing their adoption of telehealth services. My third theme was that organizational characteristics were key facilitators in CBO transitions to telehealth and virtual service delivery. So organizational characteristics refers to characteristics of the internal team. So that was collaboration and constant communication during the COVID-19 pandemic as things were moving around a lot, as well as a really highlighted commitment to care and commitment to their communities that made these transitions a lot easier for the organizations. And my final theme was that community and family were key facilitators to increased health access and are strengths that could be leveraged in future health equity efforts. There was a really strong sense of community and family bonds that were reiterated in all of these interviews, and these are really huge strengths that should be leveraged for future projects. Here are just some quotes from the interviews that I conducted. For the sake of time, I won't read all of them. But if you look at the bottom from ACRS, they said, clients didn't know how to use telehealth or weren't comfortable or didn't trust it. And maybe there was some cultural reasons behind some of that, or because of their health, they couldn't tolerate it. So many marginalized communities lost complete access. If there were no doors to walk through to get help, there was no access to services. And up at the top, ICHS representative said, it was really a testament to the team effort that it really took and everyone's willingness to put patient care first. And that was just a kind of a huge testament to the effort of the org and the provider and the care teams to do it. Going into the discussion and recommendations, the first was that prioritizing grants for supporting the development of infrastructure and protocols for collaboration and resource sharing between CBOs. So just to connect CBOs to each other, to share the resources, share the lessons learned throughout this project or throughout their transitions would have been really beneficial. The second recommendation is to increase acceptance of community-based participatory methods for development of community-engaged capacity building initiatives. Basically saying that the populations themselves should be involved in the development of their capacity building projects and how they're developing those skills. The third, more funding opportunities dedicated to strengthening internal CBO teams by focusing on the sustainability of staff positions and skills training. So ensuring that any funding going towards a new staff position or training is sustainable, and without that funding, CBOs would still be able to support those programs. And the final one is to ensure potential grantees are demonstrating a commitment to cultural humility to foster greater health equity impact. Going into the strengths and limitations, first off, the results here are not generalizable. However, that wasn't a goal of this project as it is geared towards PHPDA. Next is that Asian American used throughout this project, however, is not a monolithic group, and there will be variations between these different groups. And that the perspectives and experiences of elderly and immigrant Asian Americans are all secondhand in this project, as I didn't directly interview these individuals. However, these recommendations are targeted to PHPDA, but could potentially be relevant to other grant-making organizations. There's an opportunity to apply these results toward actionable next steps. And this work demonstrates that health equity work is nuanced and requires ongoing commitment. There's many people to acknowledge, first of all, the CBOs and interview participants, the PHPDA team, my great committee, Jane and Diem, the 539 teaching team who helped me analyze this data, School of Public Health, Department of Global Health, and my family and loved ones, many of whom are here to listen to my presentation today. So thank you.
Thank you, Amanda. Great presentation and a really interesting project. And a cute cat. I see that there's already a question in the chat. Can you tell us if you ran into challenges coming from academia and how you navigated these challenges?
Yes, I think one way that was mitigated was that I was speaking with the grantees or CBOs rather than direct program participants. And so they, for the most part, a lot of the representatives already had some familiarity with UW and health equity scholars in general through PHPDA. I think in one way that I saw this kind of, I don't know, tension, I think PHPDA didn't necessarily have as rigorous of methods in mind when I started this project. And so it was a much longer process than we all anticipated to do interviews and analyze the data and come up with the results. But they were very understanding and great to work with. And so I think that would be one way that academia kind of came into tension with this project.
Thank you. We still have a couple more minutes. I guess I can ask a question in that time. One of the things that I think we saw in the pandemic over and over again was organizations really struggling to be nimble enough to adjust their grant making and their priorities kind of in real time. And I think it's really cool that PHPDA is kind of doing this, you know, making these efforts to really understand the needs of the community for future grant making. I'm curious if anything kind of came out of any of your conversations around how PHPDA could be more nimble in the next pandemic, the next crisis, the next kind of unexpected thing that affects marginalized communities.
Yeah, absolutely. It's actually interesting that it actually came up repeatedly in my conversations with representatives that PHPDA was very nimble and was very flexible in their work. They absolutely understood that there were challenges. One of the organizations that I didn't get a chance to speak with, but I did read their reports. They basically had a grant completely in place, the project in place to do in-person traditional Chinese medicine with their program participants. And that was set to start, I think, maybe even March of 2020. So obviously that immediately was off the table. They weren't able to do that. And PHPDA allowed them to keep their funding. They kind of revised their project and then was able to go back and say, well, we're not going to do that anymore for obvious reasons, but we're going to do this instead. And so that was a huge example of that. But I think also, you know, for programs that maybe aren't meeting all of their measures or their deliverables exactly on time because of external pressures, I think PHPDA has traditionally been very, very understanding of that.
Great. Thank you. We're at time, so we will move on to our next presenter, Sunita Saad, whose title is Exploring the Post-Conflict Reconstruction of an Effective Health System in Sudan. Her committee is chaired by Dr. Steve Gloyd and supported by Dr. Kristen Bima-Sophie. Sunita, I saw you. Oh, there you are.
Yeah. Hi. Okay, let's try and see how we can share screen. Oh, yes. Perfect. Can you see my screen all?
Yep, looks perfect.
Okay. Hi, everyone. Thank you for attending my thesis presentation. My name is Sunita Saad. I conducted exploratory qualitative research looking into the reconstruction of an effective health system in Sudan post the current conflict. This is an overview of how the presentation flows. And just to give you context, Sudan is an East African nation. Its health context is marked with high maternal mortality and infant mortality rates, and along with recurrent outbreaks of emerging or re-emerging infectious disease such as malaria. The study focuses on two distinct time periods, looking at the transitional period from 2019 to 2021, and then reflecting at the post-conflict era. This is a timeline that shows the flow or the process, the development process of the National Health Policy and Strategic Plan, along with distinct political events that had an impression on the health system as a whole. Ending with the current conflict that has led to over 15,000 deaths, and this is a highly underestimated number. It had led to displacement of millions, along with near complete destruction of the health system in Sudan. So the study's objectives are to examine the lessons learned during the transitional period and to provide recommendations for the post-conflict era. My positionality is I approach it as both an insider and outsider. I am Sudanese, born and raised, and I have worked for some years in the Federal Ministry of Health. But I'm also an outsider per my current physical position and having used skills and tools that I have gained in my journey, my academic journey in this school. So the study employed the World Health Organization's health system building blocks framework, focusing on leadership and governance, financing, and healthcare workforce. I conducted 13 interviews and aiming to for total of 18. The framework was used to guide to develop the interview guide and to conduct the analysis, the thematic analysis on the collected data. And this is a snapshot showing how Atlas TI, showing the part of the application, part of the analysis process using Atlas TI. So the results, were categorized into 3 main themes based on the framework, starting with the leadership and governance, and then on distinct time periods. So for the transitional period, so during the transitional period, it was characterized with openness in political engage and in openness of the political atmosphere, but it was also there was also high political instability, fragmentation in aid coordination, and centralization of policies. And the recommendation for the post-conflict are obviously peace as a starter is a priority, along with high political engagement, higher leadership engagement in the health system, and emphasis was placed on effective coordination and overcoming implementation barriers by utilizing or by institutionalizing organizational health management systems. For the healthcare financing during the transitional period, centralization was also a theme in resources, along with, and when it comes to the health financing, when it comes to the health financing, when it comes to the financing of the health insurance, the current collapse of the health insurance fund was used as an indicator for its dysfunctionality. And the recommendation for the post-conflict era for the health financing are to direct resources towards primary healthcare and surveillance and strengthening surveillance. And for the health and for the healthcare and for the health insurance fund, it was recommended to centralize its control in the Ministry of Health and to invest more public funds, to enhance, invest more public funds in the insurance. Finally, for the healthcare workforce, for the HRH, during the transition period, there were high turnover rates on all levels. The inadequate infrastructure of the health facilities impeded successful redistribution of the healthcare workforce to remote and rural areas. And when it came to their redistribution, participants were not confident enough in their knowledge to either draw lessons or give recommendations. But recommendations for general for HRH were to focus on mapping them based on their current on their specialization and their current location, geographic location. Investment must be made into strengthening localization of responses, and for the retention, proper incentives must be made, proper incentives and linking their professional development with their redistribution were recognized as the best way to sustain the redistribution. Finally, to conclude my recommendations, when it comes to leadership and governance, stability and coordination is the main recommendation, particularly focusing on not only peace, but also on when it comes to the decentralization, it should be based on healthcare functions. As for the financing, sustainability in implementation was also the main recommendation. And this can be achieved by employing sustainable financing models and focusing on efficient uses of the limited resources that are available. Finally, for a healthcare workforce, it was incentives, proper incentivization, such as also supervision, investing in their local and building their capacity, particularly on the local level.
3 minutes.
So the study's limitations are, it's limited generalizability because it's based on Sudanese context and its particular period, political events during that period. There is underrepresentation of the broader healthcare workforce because the study, majority of participants were either current or previous leaders in the health system. There is difficulty in producing because of the war and because of the volatility of the war and its dynamic nature. There is difficulties in producing concrete recommendation for what the health system would look like post the current conflict. Okay, first of finally, thank you all. I would like to thank, for starters, the participants for taking from their time to partake in this study and their enthusiasm. Dr. Akram Atom, who was really helpful in the formulation of this study and his overall advices. My thesis committee, Steve Gloyd, who is my committee chair, my personal mentor and my friend. Christine Bimasufi for her great insights and my committee member. My research assistant, Sarah, whom I could not have done this work without her support and dedication. And to my family and friends, who I hope are attending this session. And I'm done. Thank you.
Thank you so much, Sunita. What an important project. Yeah, just so important, so interesting. Yeah, really impactful work. Congratulations. I have a couple of questions. And please, in audience, as usual, please participate while I pass the time by asking my question. So my one question is kind of personal. Like, what was the experience like for you to be working on such a heavy project that affects you so personally? And bridging that kind of insider-outsider identity? That's my first question. And then my second question is, I'm curious what your participants said about the role of the international community in assisting rebuilding. Okay.
Well, thank you, Kesha, for your question. The first one, well, my experience, it's hard to summarize it, but I guess I will say that my main focus was on doing something related to Sudan. This is how this study was formulated, and I think that was a way for me to personally give myself hope of the war is going to end at some point, inshallah. So I wanted something that could help in the future. And being an outsider, I think for me, being an insider made it easier for me to understand when people were referencing specific events. But being an outsider actually allowed me to kind of disconnect from the current context of the war, because I tried my best in conducting the interviews to try to focus on, I understand the current the level of destruction is unbelievable, but again, at some point we're going to rebuild this, hopefully. So let's focus on that. And I think being grounded in my discussions with Steve and my committee and in the work in general made it easier for me to do that, to kind of separate myself as a Sudanese, as someone who worked in that context, and be like, okay, so how do you think we should approach this? Your second question, I'm sorry, I forgot your second question. Can you repeat it, please?
It was about the role of the international community, whether that came up in your interviews.
Oh, yes, it did. This study had a lot of findings. So what I said is barely scratching the surface of where it's going to be. But the international, so it was interesting because the international community, some participants looked at the support of the international community, and they were very open. They were supportive, particularly with the the change in the political context, and Sudan being removed from the list of countries that sponsor terrorism and so on. But when other participants also critiqued how this openness or this engagement was not necessarily on the level that it should have been practically, like, for example, still being very rigid in their funding modalities, which is something that now I think the international community could be regretting, considering that now the war, they have to change how they're providing their support in Sudan. And now they're looking at civil society, which at the time of the transitional period was a priority, but it wasn't necessarily treated with the same level for the government as well as the international community. Another thing, almost all participants emphasized on how the international community completely changed their policies in dealing with Sudan and going to providing direct services of I would say overcoming, or I don't know, just like cutting ties basically with the government in conclusion. I hope that answers.
Thank you so much, Sunita. Yeah, just such important work. Steve, I see your hand is raised.
Yeah, I wanted to add my kudos to the work that Sunita, that you've done. I think it's really amazing. I would love that if you could explain a little bit, and some of this I already know, but explain a little bit about the optimism during the transition period, because it was this really amazing time that you've explained to me. And then your relationship with Dr. Akram, who he is, and his role both in the development of healthcare in Sudan and also in your study.
Okay, thank you. That's an interesting question. I don't think the time will be enough to answer it, but I will try. So what was fascinating about the transitional period is that there was high commitment to improving the health system. There was high commitment to rebuild the country as a whole. And this translated into all sectors, but particularly health, because for some reason, there's a historical relation between doctors and medical field and political events. But the transitional period really helped in the optimism around the potential of what Sudan can be, and that this is, especially after 30 years under Omar Bashir, what this could offer. A lot of people just came not asking for money, not asking for support, quitting their jobs overseas, and a lot of participants that they were of those people that left better positions to come back to build Sudan. So that was really interesting and important. And even the process of the policies, while some critiqued it as being centralized in Khartoum, the process of making it engage a lot of civil society organizations, a lot of people who were active in the health scene at the time. And it was a process that took time to develop, which I think was really a good idea, a good thing. My relationship to Dr. Akram. So Dr. Akram was the first minister, the first what we call the revolution minister during the transition period in 2019. He was, I did not work under him directly, but I have met him through my life, and I have known about him. And so when I reached out about this project and that I was looking into studying at the beginning, just the transitional period, he was really excited about it. And he was really excited about it. And then with my discussions with Steve, and then going back to Dr. Akram, like how we can make it not only look at transitional period, how can we produce something that is more concrete? And then it was like, how about we give recommendations to what the health sector is going to look like? And the thing that I would really like, and I appreciate it in Dr. Akram, is that he linked me, and he was really helpful in finding people who had various experience in the health system. He helped me in locating people who worked in the States, which I thought was impossible. And he gave a list of amazing participants that all had really good feedback. And it was interesting because I had my own participants, which were people that I have worked with, but Dr. Akram gave me people who were older, who had vast experience in the health system. So they kind of were able to provide a holistic view of what the health system require as a whole, for the country. And yeah, I hope that answered your question, Steve.
Right.
And I went way over time. Sorry, Will.
Thank you, Sunita. Again, congratulations on a really, really important and powerful project. Lots of love in the chat for you. And there's also one question that I missed. Deepa asked a question about your future plans. So I encourage you to respond to that in the chat.
I will. Thank you.
Okay, we will move on to our final presenter for the morning session, Mary Jane Okagbuzo. Is Mary Jane here? I hope you're here. You're here, great. The title of Mary Jane's presentation is Exploring Cognitive Disparities, Cognitive Outcomes in HIV-Exposed Uninfected Children in Kenya. Are you able to share your screen?
Sunita, can you stop share so that Mary Jane can? Thank you.
We are seeing presenter view.
Oh, sorry.
Yeah. We're still seeing presenter view, so we can see your notes.
Mary Jane, go to presenter view. Click presenter view, and then there should be an option for you to select to switch your screens.
Sorry, let me reshare. Let me share this.
Yeah, you can also put it in presenter view and then share. And I recently learned that it might give you an option to only share the slides if you do it in that order. We're still seeing your notes.
It's the presenter view. I'm wondering why.
So, there we go.
Yeah, we just see the slide now, so it looks good. Does this work for you, Mary Jane?
Yeah.
Oh, perfect. Okay, go ahead.
Hi, everyone. My name is Mary Jane, and today I'm going to be presenting my thesis, which is on exploring cognitive disparities in children who are HIV-exposed uninfected in Kenya. My thesis committee, Irene, Sarah, and Grace. So just going over my positionality, I'm a Black female physician from Nigeria with over 5 years experience. I have no prior experience in Kenya. However, I do have personal experience with people living with HIV. My role in this project was to conduct research on existing data and perform data analysis. So this is the outline that I'm going to be following. So we have 39 million people living with HIV as of 2022. And looking at the map, we see the majority of this population are in sub-Saharan Africa. We have 16 million children who have been exposed to HIV, with 90% of them residing in sub-Saharan Africa. So going over the rationale for this study, there is strong evidence of significant neurodevelopmental differences among children who are HIV exposed uninfected compared to those who are HIV unexposed uninfected in younger children. However, there are limited assessments of cognitive outcomes in older children who are HIV exposed uninfected. And research on cognitive outcomes in this group show inconsistent results influenced by both demographics and socioeconomic factors. My study is nested in the HOPE study, and the overall goal of the HOPE study is to evaluate neurodevelopmental outcomes in children who are HIV exposed or uninfected in Kenya from infancy all through adolescence. The NIH Toolbox offers standardized cognitive assessments for HIV-exposed uninfected children at lower cost, and it allows assessment of larger samples. So my first aim was to compare neurocognitive function between children and youth who are HIV-exposed uninfected and those who are unexposed uninfected between the ages of 7 to 18 using the NIH Toolbox Cognition Battery. And the second aim was to determine cofactors of poor neurodevelopmental outcomes. So this was a cross-sectional study with analysis of secondary data collected from the HOPE study, and data was collected from Kisumu County in Kenya. For our inclusion criteria, we included children or adolescents between the ages of 7 to 18 years who were healthy and HIV negative, and those whose mother's HIV diagnosis and ART timing were known. Information on demographics, maternal obstetrics history, socioeconomic factors were collected using questionnaires, and this served as our primary exposure of interest. NIH Toolbox cognitive scores served as our outcome of interest. We performed descriptive statistics, and linear regression was used to compare domain scores between groups and determine correlates of lower scores, with models adjusted for social demographic factors that differed between both groups. Our analysis was conducted using R. So using the African language adaptation of the NIH Toolbox Cognition Battery, which has been evaluated for cognitive interviewing through forward and backward translations, we assessed 5 cognitive domains. So we assessed attention and inhibitory control using flanker inhibitory control and attention tests, cognitive flexibility with dimensional change card sort test, processing speed with the pattern comparison processing test, episodic memory with the picture sequence memory test, and working memory with the list sorting working memory test. So these are visual representations of what the NIH Toolbox tasks look like. The first one is the flanker test, dimensional change card sort test, list sorting working memory, pattern comparison, and list sorting working memory, pattern comparison, and picture sequence. So just to give you an example of how the toolbox works, the first test, the flanker test, requires participants to focus on a given stimulus while inhibiting attention to other stimuli flanking it. So arrows are usually used for people within the ages of 8 to 85, while the fish is for participants who are between 3 to 7 years. And so the middle stimulus is either pointing in the same direction or opposite direction of the flankers. So overall, we had 209 participants in the HEU group and 209 in the HEU group. We had 51% males in the HEU and 48% in the HEU group. Our median age was 12 years for those for the HEU and 13 for HEU. HEUs were more likely to be orphaned and vulnerable compared to the HEU. Breastfeeding duration, the median breastfeeding duration was 6 months for the HEU and 18 months for HEU. HEU mothers had fewer years of education, they were older, and were more likely to experience mild or severe food insecurity. Among the HEU mothers, 56% started ART before pregnancy, while 43% started after pregnancy.
About 4 minutes.
So comparing the cognitive domain scores between both groups, HEUs had significantly lower working memory and processing speed scores compared to the HIV-exposed uninfected children. And these differences persisted in models adjusted for age and food security, as well as age and obesity status. So going over the cofactors associated with neurodevelopmental outcomes among those who were HIV-exposed uninfected. Males had higher working memory scores and episodic memory scores. Higher maternal age was significantly associated with increased processing speed and episodic memory scores. Increased maternal years of education was significantly associated with increased processing speed and attention and inhibitory control scores, while mild and severe food insecurity were significantly associated with lower episodic memory scores. So in conclusion, children exposed to HIV experience deficits in memory and processing speed. Biological differences between males and females may lead to neurodevelopmental impact from HIV exposure. Maternal and socioeconomic factors influence cognitive outcomes in children who are HIV exposed and infected. And so this creates opportunities for targeted support and interventions for optimal development. Our study was strengthened by the large sample size. However, this was a cross-sectional design, and so it limited its ability to establish causal relationship between HIV exposure and cognitive outcomes. Our study was drawn from one county in Kenya, and so this might not be representative of the HIV-exposed and infected population in Kenya. And also the issue of recall bias, as mothers may be unable to remember maternal behaviors and events that occurred during pregnancy.
2 minutes.
So I want to acknowledge my committee, Irene, Sarah, for the exceptional support and guidance throughout this project, my amazing faculty advisor, and my family for their continuous inspiration. Thank you.
Thank you, Mary Jane. That was a very clear presentation, a really nice project. As usual, I will ask the first question while other people are gathering their thoughts. As we know, neurocognition is heavily influenced by parenting and socioeconomic factors. I saw that your models were adjusted for food security and age. But did you run any models where you adjusted for other maternal factors like maternal education, family size, birth order, income, like those types of things?
So when we did the descriptive statistics and we the p-value for maternal age education, they were not significant. The p-values weren't significant. So we used the p-values that were significant. So OVC status, food insecurities, and age.
Got it. Thank you. Any other questions from the audience?
There was one
I see
question.
one in the chat. Thank you, from Agnes. Is there a separate analysis for the younger children? Is there a reason for 7 and above?
So we used participants who were between the ages of 7 to 18 because there were analyses done for the younger population. But then while we're conducting our research and literature review, we had limited data on children who were school age and older children and youth. And so that's why we focused our research on that population.
Thank you. Any other questions? Okay, well, we are right on time to finish our morning session. So thank you for closing us out, Mary Jane. Congratulations to all the presenters. We will take a 1-hour break and we will reconvene at 12:50 or whatever time that is where you're located in an hour. Thank you very much.
I'm come from Mongolia, and I have some working experience on the non-communicable disease, and we did secondary analysis, and I was included in each and every step of this study project. And I declare I have no conflict of interest. The country I come from, people drink the sotete, or the milk tea, which is a traditional beverage that includes a lot of salt. And there's some studies reported that people who consume the milk tea, there is a high risk of consuming too much salt. That's the reason why I included in this project. And national health and nutrition examinations were just briefly intense. We started collecting data for the Asian community in 2011, and post-study reported that the Asians had the highest sodium intake compared to the other groups. But there's some evidence gaps still remain, and as far as we know, there is no study conducted that association between the nativity and sodium consumption. And no studies have combined data from the 2011 to 2020. 2020 is the life cycle, and few studies just conducted on the sodium to potassium ratio intake by the race ethnicity groups in the enhanced setting. This is our conceptual framework model. For the further slides, I'm going to use the healthy or the unhealthy diet term when addressing the sodium to potassium ratio intake, to be more concise and brief. And this conceptual framework model is modified and borrowed from Buddha's model for the dietary equilibration. And we grouped our variables into three main groups: demographic factors such as the race, ethnicity, sex, and age. The second group is the health and diet-related factors, including the BMI, hypertension, and energy intake. The last group is the social determinants of health-related factors. As global health students, I want to estimate the impact of the SDOH variables, and we used the seven SDOH variables that was previously reported in the enhanced setting by the other researchers. According to this conceptual model, people who immigrated to the host country, immigrated to the new country or the new settings might go through a lot of changes regarding the psychological and sociological, also the environmental factors. For example, they might have less or the high access to the free processed foods, and those changes might lead to the higher sodium intake. We have three main goals in this study. The first, we want to assess the change in the sodium to potassium ratio intake trends across the race ethnicity groups. And second, we aimed to estimate the association between activity and unhealthy diet by the race ethnicity groups. The enhance is the national representative survey, and it's the cross-section study and use the complex multi-case sampling design. We used for consecutive cycles, and because of the COVID-19, the last cycle is stopped and merged to the previous one. Because of that, it makes our data analysis process even more challenging and complex. And after this after using this exclusion criteria, we got over 23,000 people for the final analysis. Those tests specifically designed for the complex survey design method. And briefly, for the trend analysis, we used the walking white and walking Roscoe likelihood ratio tests. And we checked the linear, also the nonlinear trend using the quadratic and cubic models, cubic terms. And for the association between activity and unhealthy diet, we used the multivariable linear regression model, adjusting for the potential confounders. I know it looks like a lot of information in this table, but it's actually a pretty simple table, just showing that whether any difference by the enhanced cycle, and we found some statistically significant results. For example, sodium intake and sodium to potassium ratio intake was increasing over time, while the potassium intake was decreasing over the entire cycle. And we didn't find any significant results regarding the race ethnicity groups, also by the nativity status. And for the trend analysis, when we didn't, without any stratification, we found that increasing trend over time But this trend is only observed when we stratified by the birthplace. And this trend, this trend is only observed of the people who are born in the United States. When we stratified by the race ethnicity groups, we found a different pattern for the Asian group, and we found a decreasing trend. But when we did the border stratification by the both birthplace and race ethnicity groups, this decreasing trend only observed for the people who are born outside the United States. And there's some studies conducted in Japan and China and Korea, and they found the decreasing trend of the sodium intake and also the sodium-potassium ratio intake over time in the last decades. And we think that that might explain what we are seeing in this slide.
4 minutes.
Okay, and next findings is regarding the association between the sodium to potassium ratio and nativity status. And we found that people who are born in the United States have the highest unhealthy diet compared to the other groups. But there's a different pattern observed for the Asian group. There is no clear difference by the nativity status in that group. This is the main findings from our multivariable linear regression model. And compared to the people who are born in the United States, we found that there is a decreasing trend on the unhealthy diet as the time spent in the United States is decreasing. And compared to the people non-white Hispanic group as a reference, we found that the Asian group has the highest unhealthy diet, followed by the non-Hispanic Black group. And there is also some significant association by the BMI and also the food security status. And when we combined the SDOH variables, we found that there is an increasing trend as the number of the unfavorable number of the SDOH variables is increasing. We fit the 3 different models. Model 1 adjusted for the demographic variables only. Model 2 is adjusted for the health and diet related factors. And model 3 is adjusted for the SDOH variables. And we found that the non-Hispanic Black groups has the highest unhealthy diet, but when we include the nativity status in this model, we found that the non-Hispanic Asian group has the unhealthy diet in each and every models. Based on those findings, we found that we concluded that sodium to potassium intake ratio is increased from 2011 to 2020. And we think that prolonged exposure to the US food environment might have some significant influence on the unhealthy diet. The Asian community has the highest sodium to potassium ratio intake compared to other groups after adjusting for the possible confounders. And we think that they might be less prone to adopting their dietary habits. Thank you so much for your attention and time. Time and attention, sorry.
Thank you, Uri. That was a really nice presentation and a lot of great analysis with a really big data set. Congratulations.
Thank you.
I will encourage the audience to please put questions in the chat or raise your hands.
There's no question. I just saving time. There's a small shameless advertisement that I'm planning to organize the small conference on the Mongolia and probably between the June 9 to June 12 after my graduation.
Oh, thanks for that announcement. Yeah, so it looks like people should contact you if they're interested. I can start by asking one question. I wonder if you could speak a little bit more about, you use the language of, I think, resistance to dietary change. I wonder if you could speak a little bit more about that and what you think of some of the kind of cultural factors that preserve a traditional diet.
Okay, sure. And I'm going to go to the post slide. In the post studies that reported on the enhanced study that includes the Russian ethnicity groups, for example, the Firestone and his team. They also reported that the Asian groups for the Asian groups, the leading source of the sodium intakes was the main source of the sodium was related to the cooking process. For example, the leading source of the food was the soup or the bread and rice. But compared to the other groups, the leading sources was just the pre-processed foods like pizza and pasta and other. I forgot that other source of the source, and that might explain it. And there's also according to the GPT analysis, the countries in Asian, South Asian and Central Asia has the highest sodium intake, and I think that might explain it.
Thank you. Let me see if there are any more questions in the chat. Okay, one question. Fascinating presentation, two questions. One, fascinating presentation. I am curious how you became interested in this topic.
Yeah, I'm very interested. As I said, we love the milk tea and I love it. I drink it all the time. And there is some studies, similar studies conducted in the Mongolia, similar to the ENHANCE, and there were no publications comes from this study. So I'm planning to go back to home and do the similar study, combining those previously collected data.
Thank you. And then another question is, what were the limitations of the study?
There's a lot of the limitations. For example, as I mentioned before, because of the COVID pandemic, the last cycle was stopped, and we used the different weighting methods, and especially for the trend analysis, we used the different midpoints. For example, when you see closely, you can see that in the trend analysis, the last 2 points is longer than the other intervals, and that was pretty much challenging to address, and especially making the graphs in complex resettings. And there is also several limitations, like we used the 24 recalled dietary method. That method is used in the enhanced setting, and the gold standard is collecting the urine sample, and we didn't do that. And time spent in the United States variable was the categorical variable, and it wasn't continuous variables. That there might be a little bit less, might be a little bit bias regarding that, and some uncertainty.
Thank you. Any other questions?
May I have a comment?
Yeah, sure, go ahead.
This is Yang Fang. Great, wonderful job. So regarding the study design, we all know that for ENHANCE is the repeated cross-sectional method in data collection. However, for the study, one of the merit in study design is to use race ethnicity as the study unit in such a way that enable us to do the nationally representative cohort study. So I think that is like a really nice point. And for the strengths and the limitations, I would adjust this as a potential strength, because ENHANCE is the publicly available data, and I think it's very important to have like a rigorous research question as well as the approach. And I think one of the merit of the study design is really like how we could study racial disparity as well as have the trend analysis. Thanks.
Thank you. All right, we are at time, so we're going to move on to our next presenter, who is Bobby Haynes. So Bobby will be presenting on, I'll just read your title as you're getting your slides up. Characterization of the HIV PrEP clinical pathway in the U.S. military health system. His chair is Dr. Paul Drain, and his committee is Ronit Dalmat.
Alrighty. Good afternoon, everyone. So as Dr. Ronan said, I'm Dr. Haynes, second year global health student, and you've already heard the title of my slides, so we'll go on. So just a couple disclaimers, my usual things I have to say. I have no financial conflicts of interest, and everything I'm about to talk about is my views and my findings, not representative of any of my various employers, Army, DoD, Defense Health Agency, US government. This is just my work. Some abbreviations that I'm using throughout here, just not trying to insult anyone's intelligence, but want to cover some bases. So PrEP is pre-exposure prophylaxis. It's a daily pill to prevent HIV. ART is treatment of HIV. STI, sexually transmitted infections. DHA is the Defense Health Agency. Periodic health assessments are like an annual wellness exam, as well as a behavioral survey that service members take every year. And MSM is men who have sex with men. So a little bit of background on PrEP and HIV in the military. PrEP was approved for use in our system in 2016, and yet HIV incidence is pretty much unchanged. We still have about 150, 200 cases a year across about 1.2 million people population. So low incidence, but still present and stable. We have universal free access to care and free medications, as well as we have some policies that are coming out that are establishing standards of care. Some studies have been done on gaps in provision listed here. So some prescriber hesitancy, patient knowledge, stigma, and then a recent study out of Kaiser Permanente in California did a survival analysis looking at their clinical pathway. In our system, we have not done that. We don't have a system-wide view, and there's a big impact here in that there's a large cost difference between PrEP and ART, as well as just the impact of getting HIV and getting that diagnosis. So some definitions for my study design. Time zero was the risk identification. So if someone identified that risk for HIV based on CDC recommendations updated in 2021, so either they self-identified on a PHA, they had a bacterial STI, so that's gonorrhea, chlamydia, or syphilis, or they had a diagnosis of such. My inclusion and exclusion criteria were active duty service members for more than 6 months in the period of 1 September to end of 2023 who had a new PrEP prescription during the study period, excluding those who had an STI or a PrEP prescription prior to the period, those who had a diagnosis of STIs, and those who deployed during the time period were excluded from my main analysis. Comparators of interest were demographics listed here, age, rank, service, sex, and ethnicity, rank being a stand-in for socioeconomic status in our system, and then risk factors, STIs, MSM status, condomless sex, and alcohol and tobacco use. Outcomes of interest were time to prescription, time to pickup of medication, time to discontinuation, if that happened, and if they discontinued, time to restart. Censoring events were whether they were still on active duty, and then whether if they were not in active duty, if they still had a prescription when they left. So this is an overview of what my population was. My target population really was anyone in the Department of Defense who met the recommendations for PrEP. So anyone with an STI, anyone with high risk factors. That was not a feasible data set to pull. So that's what I'm missing here is people who never got a prescription or never started a prescription, but I can at least get a good overview from what we have, which is those who received a prescription, picked it up, and then following them through to the end of 2023. My aim here was to characterize the PrEP pathway and evaluate risk factors based on demographics and behaviors, hypothesizing that MSM service members would be 20% more likely to get a prescription, and that time to discontinuation on average would be the median would be about 6 months, which is national average. And I believe I'm missing a slide. This is a retrospective multi-endpoint survival analysis. Sorry. Some imputations for my data. STIs, substance use was all imputed from survey answers or diagnosis codes. Only counted STIs as being positive if they had a corresponding lab result. only used the first behavioral survey, and then assuming that self-report of risk factors is lower than true average because of self-report. Assuming a uniform standard of care, excluding 28-day supplies of medications, as that is a post-exposure dosing, and then the time to event endpoints were imputed based on just time of that event from the time zero. Missingness, assumed any missing was negative, and dates that were missing were counted as one prior or one after whatever was present. And here we go. Retrospective multi-endpoint survival analysis, looking at individual factors, and then conducting a Cox proportional hazards model as well, with this as the main factors here. So MSM status, sex, race, rank as well, STIs, and substance use. So what I found, this is my overall table one here. So majority were young, non-white ethnic minorities were overrepresented relative to the US population. Vast majority were low ranking, so low SES, and then about half and half MSM. So the median time to prescription here was 215 days. But once people got a prescription, vast majority picked it up in same day or within a week. Those who discontinued, vast majority stopped after one prescribed dose, so 120 days. And that was the minimum, that was the definition of discontinuing, was you get a 3-month supply, you have a 30-day grace period, and then you don't pick it up. Of those who restarted though, within about 2 months, they restarted. So this is what that looks like. We have a very slow curve of people actually getting prescription after their defined risk identification. But once they pick up, get the prescription, they pick it up almost immediately. About 45% discontinued over the time period, but the vast majority of that happened after just the one initial visit with a physician or prescriber, and they never went back. And then of those who restarted, again, took about, the median here was about 43 days. About 40% of who discontinued did pick it up again. Breaking it down into a couple of the demographics of interest, so white versus non-white and MSM. It did take, interestingly, non-Hispanic whites actually got a prescription faster, and non-MSM individuals got a prescription faster. However, for the other endpoints, there was no difference between these factors of interest. So that's shown here: discontinuation, no difference, and time to restart, no difference as well. So when I built the proportional hazards model, for the only significant factor proportional hazard was in prescribing time, and we had a proportional hazard of 0.73 about for MSM status when accounting for all the other factors. So that's meaning that it took about 25% longer for MSM individuals to get a prescription. However, the other time points, there was no significant effect. And then all of the other factors that were accounted for in the model were not significant. So the only significant hazard here was from MSM status. Accounting for maybe that, MSM plus having an STI would be more likely to get recognized as being at risk. And that turned out not to be the case. There was no difference. MSM individuals with an STI versus without, no difference. Non-MSM individuals who did not have an STI actually got a prescription faster here. Some potential reason there is that if you are not a man who has sex with men, but you have a partner who has HIV, that is a definite indication, and that is a lot easier to recognize. And so maybe that is that's accounting for this, but I don't know. Which gets me to some of the limitations of this study. So as relying on self-report and for accuracy of self-reporting, I didn't get data on the whole risk pool, so I'm only looking at those who actually got a prescription and picked it up. At a small sample size, I was using proxies for risk assessment, and then specifically for the discontinuing, I don't know if that's because a doctor canceled the prescription, or if because someone, and they didn't need it anymore, or because someone never went to pick it up again. But the strengths here, we have a large single medical record that follows you across the country, around the world, looking at the entire pipeline from identification of risk onwards, getting prescribing patterns, and a very robust data set. So in conclusion, Contrary to my hypothesis, again, MSM individuals actually took longer to get a prescription, and the majority of those who discontinued stopped after one prescription. So that is finishing up in 20 seconds. That is a source of potential intervention, where if we have active case management and just setting appointments and getting people in for follow-up, that can be mitigated, and we can maybe get a better adherence to PrEP for those who still need it. With that, any questions and feedback?
Thank you, Bobby. Great presentation. Looks like Congo has a question.
Dr. Congo, please.
Excellent presentation, Bobby. I'm just happy that I had to discuss with you when you're formulating the question, and it turned out to be this good. So my question was, in terms of PrEP use and HIV prevalence within the military, and so what is the prevalence of HIV within the military?
Yeah, so much lower.
My other question would be, of course, you alluded to it, that why MSM have a lower rate of prescription, and so what can explain the pattern of 40% restart and restarts and initiation and discontinuity? Thank you.
So I'll answer the first question there. So prevalence in the military is very low. We are pre-screened for HIV, and you cannot join the military if you have HIV. If you get it while in service, you can stay in. It's not on its own an indication for discharge. So our baseline is very low, but service members still have sex with the community, still have other risk factors, but again, much lower than the national average. I think to answer why MSM took longer, why the prescribing rate was lower, I think that has to do with the population that I got, which is those who actually got a prescription. I think if I looked at the entire population of those who had an STI and met the current recommendations for PrEP, I think you'd actually have more MSM individuals than not, just because that has been the 2015 CDC guidelines basically said MSM individuals and people who inject drugs, and that was it. So the more expansive definition, and then if you have a partner with HIV, so the more expansive definition that we're using now was not as widely known, especially in early 2021. So I think if you got the whole data set, you would see actually a higher rate within MSM individuals. I think of those the men who have sex with men and women in my study group who got PrEP, I think it was more likely that they either had, recurrent STIs that were indications, or a partner with HIV, and that is I think as a clinician, it's a lot easier to say, oh, you're for a woman, your partner has HIV, you need to be on PrEP, as opposed to, oh, you have an STI, let's just treat the STI. Hope that answers the question.
Thank you.
Thanks, Bobby. There's another question in the chat that I think we have time for. Wonderful job on the presentation. I might have missed this part, but could you please clarify what the major reasons are for prescriber hesitancy?
Sure. It was from Miraj, I think. Yeah, so the study that I, in taking that conclusion from, basically it came down to lack of familiarity with PrEP. And within our system for a long time, when it was first approved, it was only infectious disease doctors could prescribe it. We've now expanded any person who can prescribe medications, so a doctor, a PA, and PA equivalents in the Navy can prescribe PrEP. But there's a level of comfort with the lab testing that's required, the follow-up, and the indications that people just didn't have. So that may have changed. That study came out in, I think, 2020, and was based on interviews with prescribers at the time. So maybe in the past 4 years, that's gotten better. And that is definitely something I hope to look into in the future.
Great, thank you. Any other questions for Bobby? We have 50 seconds. All right, I think we can wrap it up. Thanks so much, Bobby. We will move on to our next presenter. So our next presenter is Arantxa Sanchez Boluarte, is Arantxa here? I think I've seen her actually.
She's here.
Hi.
Oh, great.
Yes.
There you are.
Fine.
Whose thesis is entitled Spatial Analysis of Cerebrovascular Disease Mortality Before and After the COVID-19 Pandemic in Peru. The chair is Joseph Zunt. The committee is Laura Dwyer Lindgren and Cesar Carcamo. Are you able to share your screen, Arantxa?
Yes. Please let me know if you can see my screen.
We see your slides. They're not yet in full slide view. Now they are. Perfect.
Okay. Well, good afternoon, everyone. My name is Arantxa Sanchez. I'm a Peruvian physician and second-year MPH student at the Department of Global Health, and I would like to present to you all my thesis work entitled Spatial Analysis of Cerebrovascular Disease Mortality Before and During the COVID-19 Pandemic in Peru. Firstly, I would like to talk about my positionality. I'm a female identifying Latina, born and raised in Peru, native Spanish speaker. I received private education in Peru and became interested in brain health research since 2015. For my current position as an MPH candidate, I'm supported by the ICTUS Fellowship. I have taken the leading role in the study design, data cleaning, data analysis, and manuscript writing. Cerebrovascular disease is a major public health concern, and it stands tall as the second leading cause of death and disability worldwide. In 2021, it accounted for 7.3 million deaths, and with Latin America and the Caribbean having the fourth highest burden of stroke. The COVID-19 pandemic further exacerbated healthcare challenges, disrupting services for non-communicable diseases like stroke. And Peru, among the hardest hit countries in Latin America, faced substantial strain on its healthcare system, with over 4 million cases and 220,000 deaths. Therefore, understanding spatial patterns of cerebrovascular disease mortality is vital for optimizing healthcare delivery. This study aims to analyze geographic distribution of stroke mortality in Peru before and during the COVID-19 pandemic. It is a retrospective observational study and secondary analysis from 2017 to 2022, using data from the National Informatics System of Deaths, SINADEF, the National Registry of Identification and Civil Status to obtain population estimates, and the National Statistics and Informatics Institute shape files for the geographic boundaries. It's important to mention that the first administrative level in Peru constitute the departments, and the second administrative levels are the provinces, and the third, the districts. And for understanding the distribution, it is important to know that Peru has the coast in yellow, the highlands in pink in this figure, and the forest jungle in green. For the statistical analysis, we estimated age and sex adjusted standardized mortality ratios for each separate year, dividing the observed deaths by the expected deaths in each area. For the spatial analysis, we used the small area estimation, specifically a Poisson log normal spatial model in R, and using mainly INLA and SF packages. Something important to mention is that expected number of deaths changes over time in tandem with the observed number of deaths, so the ratios therefore wouldn't change too much across the years. We see areas in red for those are those where there are more deaths than would be expected when considering the age and sex-specific mortality rates over Peru. And areas in blue are those where there are less deaths than would be expected. So for these pre-COVID years, we see that spatial patterns do not show much variation across years as expected. And we see the circled areas with higher age and sex adjusted mortality than the national average, which are they correspond to these northern departments in the coast and the forest. And we also see higher than average mortality in central and southern departments, and also similar patterns in the other graphs as well. During COVID, we again see that spatial patterns are maintaining across years, showing which areas continue having a higher mortality than the national average. It is the case, for example, again, for these northern departments. And we see this similar pattern for similar close by central southern departments. For example, here it's Tumbes, Piura, Lambayeque, La Libertad, which are these ones in the coast here. Then this one is one from the highlands and two from the forest. And here we also see which ones we can see here. Well, in this figure, we can see the number of deaths and the crude stroke mortality by sex and year. And we see that during COVID, mortality seemed to have a higher increase than before COVID. In terms of limitations, the CNADEF registry faces challenges in identifying garbage codes and lacks sufficient differentiation between ischemic and hemorrhagic strokes.
4 minutes.
Yeah. Additionally, rural areas experience less coverage, and there are also limitations in data availability, such as education level and ethnicity. To obtaining the population estimates was also a challenge, because our RENIEC population doesn't update its data frequently, as it depends on the person to change their own address. And also there is no official platform for district level population estimates outside of the census years. In conclusion, some regions in the northwest and south of Peru have exhibited higher mortality than the national average, while the spatial patterns did not seem to differ much when comparing by year. They clearly highlight that these constantly affected areas across years should be something to focus on. Then the heightened peaks in overall stroke mortality during the years 2020 and 2021 coincide with the global COVID-19 pandemic. This highlights the vulnerability of healthcare systems and populations during crisis. Therefore, future efforts should prioritize resource allocation and interventions, not only in historically underserved areas, but also in both bolstering the resilience of healthcare infrastructure to ensure effective responses to health crisis and long-term public health challenges. Lastly, I believe the Peruvian government should continue improving national registries to leverage accurate data collection for better research and effective public health planning and intervention strategies.
2 minutes.
I would like to give a special thanks to my amazing thesis committee, Dr. Sand for his continued support in my career, Dr. Dwyer Lindgren for getting me through the spatial analysis, and Dr. Cárcamo for his insights on the limitations of using Peruvian secondary data. I also thank Professor Wakefield and his biostatistics course, the Department of Global Health, and my lovely family and pets as my motivation. Thank you.
Thank you. Congratulations on using spatial epi. That's an achievement in itself. Deepa has a question. Great job with a complex project. What are the next steps for this project? What is your plan for disseminating results to stakeholders?
Mhm. Well, I still, besides the fact that I need to finish the manuscript writing and getting it published, I think this is very interesting because we can see which areas have constantly a higher mortality, so which areas need to be looked at. So I really, and also this data is very big and it has other covariates. So I feel like it has, for example, ethnicity, education level. I feel like those are other things to look at, and further research should also analyze that since it is available publicly. I think, yeah, I think those would be the next steps. I'm still trying to work also on this, and yeah, other than this, I think it's important to deliver the information of which areas are which areas need to be focused for future research and interventions.
Thank you. Joe, I see your hand is up.
Yeah, thanks. So Arantxa, fantastic work with so much big data. And I know that Cesar's wife, Patty Garcia, really had a lot to do with bringing the electronic registry to Peru while she was Minister of Health. And knowing that some of the data was not as useful as we would like, I wonder if you would have advice on which data points would be areas that could be most improved if you were to look at this again, and perhaps Cesar can tell his wife and she can do the same trick again and make the system even better.
Yeah, well, that's a great question. I think that, and it happens in other countries as well. The way the underlying cause of death is registered is not always very accurate. So there is this garbage coding process that needs to be done. So perhaps one recommendation would be, and there is currently training for physicians to know how to properly fill these areas, but still a lot of times that doesn't happen. Other than that, I found I was looking at ethnicity data, because we have populations from the Andes, then from the Amazonian communities. So that was something interesting, but there is a lot of missing data there, and also in education level. So I would say those would be the main areas for me that I would have liked to be able to analyze a bit better.
That could be your future career.
Yeah.
Thanks.
Thank you.
I think we have time for one more question, which I can ask if there aren't any in the chat. Yeah, it doesn't look like there's anything else in the chat. I guess I was curious what hypotheses you have about the underlying factors that are responsible for those regional differences that you saw. And I was also curious if you saw like an exacerbation of those disparities during COVID. The pattern didn't change, but did you see that the pattern was more pronounced, which is much of what was seen in the US?
Yeah, that's a good question. So just to answer first the last part about if mortality actually increased in each of these regions. I'm still working on that, but in this specific analysis, we are not able to say whether the overall level of mortality increased because it was calculated independently by each year. however, if we see, for example, if one place is going from blue to red, then we would see that things have changed, and that there are more expected. There are more deaths than what was expected, and I believe that happened for. Yeah. So when looking, oh, sorry. I think, yeah. But yeah, yes, that's something interesting, and I wonder if did I answer the question completely? I think you said something else.
Yeah, I was asking about underlying factors that might contribute
yeah.
to these regional differences.
I can quickly respond. For
Okay.
example, here, this department in the coast, it's called ICA, and this one has faces in the past big earthquakes, and we see here that it's having this, even though it's close to Lima, which is supposed to have a better mortality, less mortality, we see here so that would be one factor, because the mortality here is higher, the earthquakes, then areas in the coast, also during the pandemic, in the northern coast were mostly affected. So yeah, it could be, it could be a variety of factors. There are also a lot of flooding. Yeah, there's flooding situations, so that could be something that impacts.
Great, thank you. We're at time, so we'll move on to the next presenter, but thank you so much for explaining your findings. Okay, our next presenter is Amelia Wilkeson, whose capstone is entitled Mercury Contamination in Suriname, Advocating for Indigenous Health from Local to Supranational Levels. Her chair is Dr. Amy Hagopian, and her committee is Dr. Daniel Peplow. Are you able to share your screen?
Yes, just a sec. Okay, can you see everything okay?
Yep, looks great.
Okay, perfect. Hi, yep, my name's Amelia. I use she, her pronouns. I'm a second-year student in the Department of Global Health, and this is my capstone project, a big pivot away from quantitative research, more into qualitative. But yeah. Before I get started, I do want to touch on my positionality. I am a white cisgender US citizen who is also non-Indigenous. My previous work has been in confidential sexual and domestic violence advocacy, along with community outreach and violence prevention. And while my project setting is in Suriname, I have not been able to travel to the country or its neighboring countries. And as my topic is on gold mining as it relates to mercury, I kind of would have described that relationship a little briefly. So gold mining employs an amalgamation technique in which mercury is combined with ore to extract gold. And approximately 20% of gold comes from artisanal and small-scale miners in over 70 countries, including Suriname. This process is unregulated in Suriname, and the mining harms the environment and human health through the contamination of soil, water, and anthropogenic mercury emissions. What you're looking at now is a diagram of the process of mercury toxification. Burning mercury releases it into the air, where it can settle on land or bodies of water. Additionally, solid waste from mining operations can deposit mercury into the environment, and once present, microbes can transform mercury into methylmercury, which is a more toxic form of the chemical. This methylmercury can then be absorbed by organisms, ultimately entering the food chain and posing risks to both aquatic life and humans who consume contaminated fish. You might be asking, why is this relevant to Indigenous work and advocacy? And the answer is simply because this process is exactly what's happening in some areas of Suriname. So as you can probably guess, my setting is in Suriname, which is a country located in the northern part of South America that you can see kind of on this globe right here. And specifically, I'm working with the Wayana language territory, which is primarily along this river and these dotted lines right here on this map. My work has been with the Suriname Indigenous Health Fund, who I will be referring to as SIHF for the remainder of the presentation. SIHF works with Indigenous communities in Suriname using participatory action research to collect evidence of mercury toxicity and to advocate for the human right to a clean, healthy, and sustainable environment, as has been stated by the United Nations General Assembly. The SIHF is a nonprofit, non-governmental organization based in the United States, and their research has been met with oppression on legal, ethical, and governmental levels, which has resulted in the organization's reluctance to have a public face. Their mission is guided by activism to dismantle terra nullius as it exists today. Under terra nullius, lands and resources occupied by Indigenous people are considered empty and vacant. The legal framework renders the lives and life years lost of the Indigenous people living there without value and equal to zero, thus affecting cost-benefit analyses and the allocation of resources and services needed to address what is a health crisis that exists on a global scale. Terra nullius is the overarching root cause of death, disease, and disability among Indigenous communities that are displaced by economic development policies that originate at the supranational level of economic governance. So based on all of this background information, I, with the help of my mentors, developed sort of a guiding question for my capstone project, which is, what methods should global health researchers use to address global health crises in settings where governments use force to oppress and silence those addressing complex health problems? And my answer to this question in relation to SIHF was to develop a website. And I came to this conclusion because websites are regarded as official references that people across the world can rely on for local and global health affairs. And they can also contribute to the procurement of quality health services and access to reliable information. Part of my process of coming up with the idea to develop a website was just kind of based on my work with SIHF and what I kind of witnessed through that process. Most of which included observing that there was significant data that has come out of the organization through their participatory action research initiatives that links gold mining practices to mercury toxicity among the Indigenous population in the Wayana language territory. And until September of 2023, this issue seemed to be underground, ignored, and not taken seriously. But in September of 2023, the New York Times published an article on mercury toxicity along the Moroni River, gaining more global attention than the topic has received in over the past 2 decades. From there, I developed another question, which is, what happens when people try to Google initiatives, organizations, or more information on the crisis in Suriname? And the answer is this: you're met with an error code and little to no information on the organization or the problem itself. So SIHF does have a website, but again, you're just kind of met with this error code. And despite the direct political advocacy SIHF has been conducting over the past 2 decades, both locally and internationally, there's been little to no changes in protecting the health and human rights of the people in the Wayana language territory who are directly impacted by the exposure to high levels of mercury through their food and water sources. What you're looking at now is just a brief outline of the ideas I created when thinking about designing a website for this organization. And initially, I started my first draft design in a Google Doc drive where I outlined different material I wanted to include on each page of the website. And once I felt like I had a basic design vision, I began researching different website development platforms that were free and easy to use, especially for those without a degree in computer science. From there, I found a program called Doric, and I began designing a website through their services, but I quickly realized that their design tools were too advanced for my level of technological knowledge, and I decided to abandon this draft altogether. Luckily, I found success in using the platform Squarespace. I found their tools really simple to use and to adapt to, and I learned how to develop each page fairly quickly. What you're looking at now is the homepage of SIHF, which is the first page you see when accessing the website. All photos on the website that I developed were provided to me by Dr. Peplow through SIHF. And this page just basically is like any other homepage. It has basic information about the organization, the issue at hand, a brief history of terra nullius, and how to get in touch with the organization.
2 minutes.
This is our About page, which provides more detailed information about the organization, its goals and missions, and kind of background information on the environmental health issue. This What We Do page outlines the research and advocacy that SIHF has conducted over the past 2 decades by listing the 3 initiatives that you can see right here. I also wanted a page where people could access academic resources that SIHF has published over the years, along with a wonderful documentary that was produced for the organization. All articles and resources on this page are hyperlinked and free for anyone to view, thanks to public access publications, which is really awesome. Additionally, I designed a page dedicated solely to a new project that the organization has rolled out in 2024 titled Victim's Voice. It was important to have this information exist on its own separate page because it's a really important initiative that connects different communities who are facing similar health issues. This is our contact page. So prior to the website, SIHF had no streamlined way of adding new people to their mailing list. It's been word of mouth for almost over 2 decades. And so this is just more streamlined. Here is our funding page. Rather than having a button that said give us money, I developed one that said take action. We provide info on how to donate and then also how students can get involved. Really quickly, my conclusion, I aim to complete a call to action as my final deliverable, and hopefully SIHF will find my website useful. Thank you to all of these important people. And that's it.
Thank you, Amelia. Really interesting and important project. I would love to, oh, let me see if, I thought I had the chat open, but let me see if there are any questions in the chat. I think I see one. Yes, I see one. Oh, great job, Amelia. Found your project very informative with concrete output. Do you intend to continue to be involved with this project?
I hope so. I think at the very least, it'll take some advising on SIHF on how to use the website, but I also think there's some things that aren't super finished with it that I think we could advance in the website. But yeah, as long as Dr. Peplow wants my help, I am happy to be of use to SIHF.
Great. And there's another question in the chat regarding demographics in Suriname. Who are the ruling class? And do the Wayana have any representation in government?
That's a really good question. So Suriname is a formerly colonized country, and only until recently you can correct me if I'm wrong, Dr. Peplow, but only until recently did they gain independence from the Dutch, I believe. And primarily the population is situated like on the Atlantic Ocean and around this port city. So the indigenous population really doesn't have, I don't believe, have government representation, but the Wayana people have kind of like been pushed out of government and of accessing basic human rights continuously even after the country gained independence, which is really unfortunate. So part of that is also due to the mining industry's economic contributions to government in the country. So yeah.
Thank you. I have one question. I saw you talk about participatory action research, and I'm wondering if you could comment on whether and how you use participatory methods in your project.
So my project was actually mostly just looking at my project mostly just kind of examined all of the data that SIHF has produced over the past 2 decades. So I was not involved directly in any of the participatory action research. But through this process of working with SIHF, conversations have been involved with Dr. Peplow and people directly in Suriname in the Wayana language territory. So everybody's looped in.
Thanks. Any other questions?
Yes, I have a question.
Yeah, go ahead.
Amelia, could you please share if there have been any thoughts on ensuring the long-term sustainability of the website? As I know, Squarespace is a paid platform, and yeah, in the long run, what are the plans?
Yeah, that's a really good question.
Miraj was a little hard to hear. Would you mind repeating the question, Amelia?
Sure.
Yeah, sure.
Yeah, could you please share if there have been any thoughts on ensuring the long-term sustainability of the website?
So ideally, the website will be able to increase people who are aware of the organization, which ideally would also increase funding. And with more funding, we would be able to sustain a website that is paid for. But I think Dr. Peplow can probably touch more on like the funding aspects of the organization, especially because right now part of the silencing of this organization, as you can see through our donations, is we're kind of only able to receive donations through Venmo, as our fiscal sponsors had been hacked recently. So
thank you so much.
Thank you. Thanks, Amelia. Congratulations.
Thanks.
We actually have a short break in our presentations due to a cancellation. So our next presenter, Nuno, will be presenting at 2:05. So we'll take a break. Menace, whose thesis is entitled Evaluation of Maternal and Infant Tuberculosis and Nutrition Programs in the HMNASA Organization. His chair is Dr. James Pfeiffer, and his committee is Dr. Marianne Mercer. Your slides look great. The platform is yours.
Thanks for the time. I little bit changed my title. I'm Nuno. I'm going to present to you my thesis titled Evaluating HMNASA's Tuberculosis Screening Services and Patient Management by District Assistant in Timor-Leste. My thesis chair is Dr. James Pfeiffer, and my committee member is Dr. Marianne Mercer. A little bit information about my positionality. I'm a male, I was born and raised in Timor, the country I conducted my study. I have a medical degree. I'm currently a DGH student. Some information about Timor-Leste TB country profile. Timor-Leste placed as the second highest TB incident rate in Southeast Asia, with incident rate a little bit under 500 per 1,000 population in 2022. The organization that I was working with was HMNASA. Is a local organization, received a sub-award from Timor-Leste, the Minister of Health and the Global Fund in 2022 to conduct TB screening within 4 health centers. They have a very high equipment in the mobile van. It's a pilot project to assess effectiveness which might be implemented in other municipalities if the project is successful. The goal is to contribute to the reduction of TB incident by 50% in 2025. I had two research questions. The first was, what are the facilitators and barriers identified by HAMNASA in providing TB screening provision? And the second was, what are the successes and challenges faced by district tuberculosis assistant in TB patient management? So the study design was mixed method explanatory sequential triangulation design. I did not collect quantitative data. The quantitative data were provided by HAMNASA and did have provision. I was there only collecting qualitative data through one focus group discussion with mobile van health personnel for key informant interview and two in-depth interview. All of the transcripts remain in the original language because I'm a native speaker and I did not use any software to analyze my data. The code I did inductively. Here are theory of action or theory of change. I'd like to point it out that HAMNASA mainly focus on the community engagement awareness of TB and case detected. They usually go to the community and provide some information related to TB. Once the patient feel encouraged enough, and they will visit HAMNASA mobile van to do some TB-related tests. Once they are diagnosed positive, the mobile van personnel will prefer those with TB positive cases to CSC to initiate the treatment. I like to mention that according to Timor-Leste guideline, they have to take the medicine in the health facility like every day during the 6 months of TB treatment. Before they started the second phase of continuation phase, they will do some of tests just to make sure the TB patient actually taking the medicine correctly, and to ensure they haven't developed antibiotic resistance. Here are qualitative findings within the HAMNASA mobile van because they do case detect and bacteriologically confirm. So I'd like to point out in the very last quarter of the data, which was quarter 4 in 2023. So these are the targets the HAMNASA needed to achieve. And look at the 3 indicators, which were a number of TB cases detected, bacteriologically confirmed, and number of site visits. They are able to get a very low number compared to the targets. So that the achievement for both indicators, which are number of the cases detected, bacteriologically confirmed, like just around 10%. Looking at 2 overall quarters, the achievement for both indicators were lower than 60%. They did a little bit good in Q2 in 2023, but just a little bit above 60%. Here are distribution of patient among the 4 health facilities that HAMNASA collaborating with. Just look, we can tell like they have a very poor data management. So starting by in Community Health Center Comoro, so they have number of detected cases higher than total patient evaluated. I was expecting to see the data that around like in CSA Veracruz, like total number patient evaluated and number of detected cases were in the similar range, and they keep increasing as the data going to the right indicators. So I'd like to point it out, I mentioned in this previous slide that some of they have to take medicine in the CSA. So the CSA Comoro or CSA Formosa and Mekora were the only CSA that follow the guideline. So based on the data collection, they say that during the interview, they say that they are actually following the protocol. That's why they have low number of loss of follow-up. So loss of follow-up refers to like if the patient did not come to the clinic within 2 months to take their medicine.
Or sorry, 4 minutes.
some of the qualitative findings for facilitators and barriers. For the facilitator, they used to bring the container that contain student to National Hospital to do some tests, but now since AMNASA go to their CRC, they no longer to do that anymore because they have equipment to provide that kind of services. We can also see like the collaboration between doctors in the village that far from Delhi. They usually inform to the chief of village, and the chief of village contact AMNASA and they visit and they do some, they run some tests within the community, and they usually found TB. They usually detect TB cases. Some other barrier in the focus of discussion within AMNASA mobile van. Sometimes they have to rely on their own transportation to initiate the collaboration with the chief of villages. So the road is not comfortable, and they use the motorbike. And I like to mention as well, they're all women, so they don't feel comfortable to going out too far from Delhi. Another barrier is patient did not bring back the container for the Sputnik test. They do some X-ray tests and they need to confirm. So they need on the next day they have to bring that early morning sputum. But sometimes the patient are kids. They can produce sputum, and some of them say that, oh, I have dry coughing, so I cannot produce this sputum. Some of the findings, patient abandoned treatment is by receive $30. The Global Fund provide $30 for patient once they finish the completed treatment. But sometimes patient need one more time to commute, so it's difficult to them to commute, and also difficult for them to go to CRC every day. So I mentioned earlier, two facility actually following guideline, but the others they did not. So they have to adjust their treatment for adherence based on patient condition. That sometimes they work, they cannot go to CSC every day to take the medicine. When I was there, the van underwent some repair. So all of the most of the component in the mobile van is a software based. So when the system went down, they have to contact manufacturer in India to fix the system. Usually it takes more than a week to fix. So when mobile van underwent the repairment, they did not provide services. Some of discussion, even though the mobile van facilitate TB screening, they did not hit the indicators. Some TB-related stigmatization and low economy status and distance to commute. The factor contribute delay in initiate treatment. Those who follow the guideline better in terms of like lower number of loss of follow-up. Some of data related to TB inadequately collected. When the mobile van underwent the repairment, they did not provide services, so it's impact the services. Some of the recommendation, I prefer they go to like outside of Delhi to provide services that to community who not live around the CSA. So reassess the target, maybe that the indicator is too high to achieve. So I think it's better to provide the incentive before they start the treatment. So all of the CSA have to follow the guideline, provide some of training for the mobile van to conduct the education session, do some regular check-up, and do a lot of data quality assessment from within the ministry. So, thank you.
Thank you, Nuno. Congratulations. That was a great project and great presentation. While people are coming up with questions, I will ask you, what is next for this project and for you? How do you plan to disseminate these findings? How would you like them to be used?
So I definitely I will go back to Timor. So I definitely I like to sit with AMNASA team or maybe presenting my findings to them, especially like evaluating like the strategic plan just to increase the number of detection and new cases of TB. Thank you.
That's great. Steve, I see you have your hand up.
Yes, I do. Thanks very much, Nuno, for that great presentation and interesting project. I was struck by your data around the management of cases by the community health centers. And it seems like identifying more cases when you bring them to a community health center that seems either not to manage the data well, or it's hard to know what's going on. To what extent is Hamnasa or this whole project working with the community health centers to be able to improve their both quality of data management and quality of care?
Hamnasa mainly only focuses screening. They usually just bring the patient to them, but they do not. When I was there, I didn't see like collaboration with the data quality control. But there also was another organization that focused on screening in terms of once they found a patient positive, they will tell that organization to do like contact tracing screening within with the family who with the person that just diagnosed with TB. But there's no data shared between Hamnasa. But I also just remember that they usually do a quarterly meeting between Hamnasa, daily health provision department, and all of the municipality. But somehow the data still has a lot of issues. Thank you.
Thank you. Any other questions? All right.
Maybe I'll just jump in real
Go ahead.
quickly without
Yep.
just say great job, Nuno. I know you've been working really hard on this, and it became, as Steve pointed out, it became challenging because the data, it was hard to use the data to tell a story. And so that's one of the recommendations is there needs to be better data strengthening and to be able to track people, right? It was just very hard to follow that treatment cascade. So Nuno's work hopefully is going to contribute to taking a harder look at that. Is that fair to say, Nuno?
Thank you. Thank you for your support. It's my thesis chair. So.
Yeah, nice job.
All right. I think if there are no other questions, we will move on to our next presenter.
Thank you.
Our next presenter is Miroj Muhudinov. His thesis is entitled An Examination of the Potentials and Limitations of Incorporating Digital Technologies within Community Health Worker Systems in Western Kenya. His chair is me, and his committee is Nancy Buchanan.
Thank you so much, Kashat. Hello, everyone. Thank you for being here today. My name is Miroj Muhudinov, and I'm an MPH candidate. The title of my presentation is Digital Integration in Community Health Worker System in Western Kenya. I'm honored to have had the guidance of my thesis chair, Keshat Ronen, and the support of my thesis committee member, Nancy Buchanan. Before we dive into research, I'd like to share my positionality statement. I am an MPH candidate with a Master's in Security Studies, Western educated, originally from Tajikistan. I identify as a cisgender queer man. My background in digital health influences my perspective and potential biases in this research. I was not involved in the fieldwork, and I don't have prior experiences in Kenya. Let's define some key terms. Digital health is the use of digital technologies to enhance health services, including mobile apps, telemedicine, and electronic health records. And community health workers are frontline public health workers who provide essential health services and provide a close understanding of community they serve. Community health workers are lay health workers, meaning they are trained community members, not formally trained medical professionals. Kenya's Ministry of Health has launched an ambitious strategy to promote digitization in community health services in 2022 until 2025. By introducing ICHIS, the strategy seeks to enhance service delivery, streamline data collection, improve communication, and support decision-making. However, transitioning community health services from paper to digital across the country may be challenging. The goal of my thesis is to address the strengths and limitation of digitization from the perspective of various stakeholders. And as you can see, there's also operational features of each is provided on the table. And the aims of this study are twofold. The first one is examine the strengths of digitization in community health workers' workflows for enhancing the maternal and child health outcomes. And second is to examine the challenges and limitations of integrating digital technologies into community health workflows. Now let's go over the methodology of our study. This is an exploratory qualitative study using a human-centered design methodology. The study is nested within the CHV NEO study. The fieldwork was conducted from April to August 2022. The study took place in Kisumu and Siaya counties, Western Kenya. The primary objective was to understand the impact of health system digitization on maternal and neonatal health outcomes. The team conducted focus groups with the community health workers and prepartum women receiving community health services, and individual interviews with supervisors, facility nurses, and policymakers. For this research, I conducted a secondary analysis of data that had already been collected. And let's dive into strength. The number one is improved workflow efficiency. Digital tools automate and streamline routine tasks, such as scheduling, data entry, and reporting. This reduces the time for community health workers spent on administrative duties, but allowing them to focus more on direct patient care. Task reminders and automated alerts help community health workers stay organized and ensure that no critical activities are overlooked. Digital platform reduces manual record keeping and data management burdens, creating a less stressful work environment for community health workers. Clear task reminders and structured workflows enhance their confidence and efficiency, improving job satisfaction and fostering professional growth. Additionally, tracking their performance with digital tools motivates community health workers and provide tangible evidence of their contributions to community health. Based on the finding, digital systems ensure accurate, consistent, and accessible data, which is crucial for monitoring health trends and identifying issues. Real-time data collection and reporting enable timely interventions and adjustments in care strategies. Enhanced data integrity and verification also reduce the risk of errors, providing a reliable foundation for health planning and policy making. And in terms of usability and configuration issues, community health workers encounter usability and configuration challenges with the apps, such as persistent and incorrect reminders for tasks that are no longer relevant, like pregnancy follow-ups and after miscarriage. Additionally, the app sometimes failed to accommodate special cases, not allowing community health workers to add necessary notes or updates. Limited access to appropriate technology is a major barrier. Not all community health workers have access to digital devices or reliable internet connectivity, which are essential for utilizing digital health tools. Some participants noted that their devices frequently experience issues, making it difficult to use the apps consistently. In terms of sustainability, maintaining and updating digital tools over time can be challenging. Initial implementation might be successful, but ongoing support and updates are often lacking. This lack of maintenance can lead to issues such as outdated software and unresolved bugs, reducing the overall effectiveness of the digital interventions. Privacy concerns and trust issues can affect the willingness of community members to share personal information. Community health workers often face skepticism from patients when collecting data, with people questioning the purpose and the use of their information. This skepticism was frequently mentioned in different focus group discussion, with patients expressing concerns such as, "You always ask for my phone number, what do you use it for?" Or, "You're always eating from our names and we never see this thing that you write." These concerns highlight the need for clear communication and transparency about data usage and to build further trust.
3 minutes and 20 seconds.
Thank you. Recommendations. Number one, investing in ongoing training and professional development for community health workers to ensure they are proficient with digital health tools and can adopt to new technologies effectively. The second one is implementing clear communication strategies to address privacy concern and build trust, which is very crucial. Community members need to be aware of how their data will be used and how it will be protected. Any misconceptions or rumors should be addressed officially to ensure transparency and maintain trust. Third is developing digital health tools with user-centered design approach, allowing for customization to meet the unique needs of community health workers and their communities, which includes resolving usability issues and accommodating special cases. And the last one is focusing on sustainability by securing long-term funding commitments to ensure continued support for digital health initiatives and the ongoing maintenance and upgrading the technology and devices. Limitations. So number one is geographic constraints. Conducted solely in Kisumu and Siaya counties, the findings may not represent other regions, particularly urban or non-Western settings, which could have different technological infrastructure and healthcare challenges and needs. And the second one is technology usage variability. At the time of data collection, rollout of digital tools was variable across this study region. Different participants had therefore been exposed to different types of functionality of digital tools. This led to variability in participant responses that may be difficult to interpret. Conclusion. In conclusion, digital technologies can significantly improve community health workflows and enhance maternal and child health outcomes. However, it's important to address usability issues, data privacy concerns, and access to technology. Investing in training, clear communication, and sustainability can maximize the benefits of digital health tools for community health workers and their communities. Thank you so much. I extend my heartfelt thanks to Dr. Cachette and Dr. Nancy Puttkammer for their invaluable guidance and patience and their unwavering support throughout this research. Their expertise and constructive critiques have been crucial to my research. Additionally, I would also like to thank the study participants and the members of CHV NEO team who collected and helped analyze data. Their contributions have been essential to this work. And also, I would like to thank my scholarship program, Fulbright, for their consistent support and in enabling me to be here. Thank you so much.
Congratulations, Miraj. Really nice work. I'm biased, but it's really nice work. There's a question from Deepa. Great presentation. I'm wondering what your next steps are for your career and for this project.
Well, I can definitely say that the first stage is getting manuscript done, and if it's possible, maybe publishing it. And in the long run, I want to take my interest further in terms of digital health and explore other areas. And it was really good for me because I have never worked in this region before, and much of my work was concentrated on Central Asia and post-Soviet settings. So it was a really eye-opening experience because I can definitely say that we can develop this methods and learn from the Kenyan perspective and implement it in other regions, specifically in Central Asia, I think, which doesn't have a very strong digital health or health information system.
Thank you. There are questions about happy hour, but I don't think that's the kind of question that I'm supposed to read out.
Yes.
Any other questions? I will ask a question while we wait for others to ask. Given that you have been in the digital health field for a long time and have done projects in a number of different contexts, you talked about Central Asia, but I know you also worked with iTech for your practicum. I'm wondering if you, like, how much of what you learned from these interviews is similar to other experiences in digitizing health systems in other contexts versus how much was really kind of different from what you'd heard before or read in the literature.
Yes, definitely. Some of the issues are very interconnected and they're very, very basic, like technology access needs and privacy. But each of the issues, they're very context influenced and they need more tailored recommendations on the regions. But I can definitely say that they are very intertwined. And in most of the low income and middle income countries, you see they have similar challenges regarding these issues.
Thank you. Yeah, and I'll just add for context, Niroj said this, but Kenya's efforts at digitization are really large and quite ambitious. So I think it's an interesting time to be reflecting on what it takes to digitize an entire community health system.
Yeah, exactly.
Any other questions? All right. Do we have our next presenter? Luyanda, is your committee also here?
Sorry, I was muted. They do have the invitation, but let me just quickly check.
We're a couple of minutes early, so we can definitely give them a couple of minutes.
I don't see the both of them on yet. No.
Okay, so maybe we can just wait a couple of minutes just so they don't miss your presentation. In the meantime, do you want to just make sure that your screen sharing is working?
Yeah, please.
I see your screen, but it's not in it's not in slide view, full screen view.
Is that better?
Yep, that looks great. All right, we can give one more minute and then we'll start at 35 minutes. All right, my clock says 2:35, so we can go ahead and get started. Our final presenter is Luyanda Ngongoma. Her thesis is entitled Evaluating Ultrasound Innovation in Malawian Antenatal Care, a cross-sectional analysis of organizational resources and referral levels. Her chair is Dr. Yanfang Su, and her committee member is Brian Weiner. Go ahead, Luyanda.
Thanks, everyone, and thank you, Keshe, for the introduction. I'm sure everyone can see that I've changed the title. So the title that I'm going with today is Powering Healthcare, a cross-sectional analysis of power supply and ultrasound availability and functionality. So my name is Luyanda Ngongoma. My chairs are Dr. Yanfang Su, who serves as my chair, and Dr. Brian Weiner, who serves as my vice chair. So my positionality, I'm a Black woman, I'm born in South Africa, cisgender, heterosexual, and I have experience in resource-constrained healthcare settings. So when I arrived in Seattle, I discovered that the city was an innovation hub for biomedical, an innovation hub in the biomedical sphere. And I became really interested in innovation and its intersection with global health policy, particularly in resource-constrained settings. Innovation is defined as the source of any improvement in the quality of services and quality of life. And it ranges from workforce changes to policy changes within the organizational context. I was then introduced to the theoretical foundation of this thesis, which is the Organizational Readiness for Change framework. The framework describes the pathway towards achieving change and change innovation implementation, and it begins with contextual factors. Of particular research interest is organizational resources. So the resource that I'm going to be focusing on is power supply. 1 in 10 health facilities in sub-Saharan Africa are without reliable power supply. There are frequent power outages in Malawi, the worst of which was in 2017, and this is due to an overloaded power grid, reliance on hydropower, and weak infrastructure. Power is important for a variety of reasons, such as refrigeration of medical stocks, operation of medical devices, and etc. The innovation that I'm interested in is ultrasound. It's important as it is non-ionizing and non-radiating. It's versatile across clinical disciplines, and it has been classified as an essential device during the COVID-19 pandemic. Critical elements needed to action ultrasound services are equipment, electricity, human resources, and adherence to local and international standards. And there are 2 types of ultrasound that I want to highlight, and that is the traditional cart-based system, which you're going to see in the picture next door, and handheld ultrasound. And so I wanted to explore the potential significance of handheld ultrasound as a future innovation in Malawi. So the aim was to evaluate the association between electricity supply and ultrasound availability and functionality within the Malawian healthcare facilities. And I wanted to use 3 questions to do that. How does ultrasound availability vary across Malawi's public health and private healthcare facilities? What is the relationship between electricity supply and ultrasound functionality and availability? And what strategic recommendations can I recommend for handheld ultrasound as a future device? For my methodology, I used the Harmonized Health Facility Assessment, which was conducted, it's a survey conducted in 2019. I used census sampling, and it was a cross-sectional design. My variables of interest, like I mentioned, were power supply and ultrasound equipment. And for inclusion criteria, I included all kinds of facilities, ranging from public to privately funded. And then I handled my missing data using multiple imputations. I used dummy encoding, and I binomialized certain variables of interest, such as my outcome. So findings. What I found was that there was a rural and urban versus urban disparity. Ultrasound availability was higher in rural areas, and that this was converse with X-rays, which showed higher in urban areas. There was a facility level impact. Secondary facilities showed highest device functionality for both X-ray and ultrasound. Ownership matters. Government-owned facilities had lower device functionality despite a high availability, whereas privately owned showed higher functionality. And there was a power availability paradox. Nearly all facilities that had a main power source often had lower functionality of ultrasound. In turn, facilities experiencing frequent outages also surprisingly showed a decent ultrasound functionality, which might allude to stronger backup facilities within those hospitals that face frequent outages. And then this is 2 diagrams that show what the different types of what different types of power sources were popular in across facility levels. So you can see for main power source, National Grid was the most popular, and then for backup sources across the 3 levels, it was generators that were most popular. So in terms of the other statistical findings that I conducted, we found that there was no significant association between a facility that has a main power source and ultrasound functionality and availability. And this was also shared across X-ray availability and functionality. I also found that there was a strong positive association between ultrasound functionality and availability with having a backup electricity source. And for generator availability, there was a significant positive association for functionality for both X-ray and ultrasound services. And then it also, as you can see from the table, you can see that facilities with fewer interruptions showed better ultrasound functionality, and those with prolonged interruptions showed worse outcomes with functionality. So this is just one of the 5 forest plots that I did to describe power reliability versus ultrasound functionality and availability. And as I described before in the previous slide, having fewer interruptions had a positive impact, and having more interruptions, so more than 2 hours a day, had a negative impact on ultrasound functionality, and both of those were significant. The other variables that you are seeing are the covariates that I included in my multivariable logistic model. 1 minute. So my recommendations in general, it's to strengthen backup power sources. This is supported by the fact that backup sources were significantly associated with better functionality. My second is to carefully consider expanding generator installation. The world is moving towards renewable energy power sources, but there was a positive effect shown or described between a facility having a generator and ultrasound functionality and availability. And then to continue working towards enhancing power reliability, so continue those policy and implementation efforts that the country is already taking. And then recommendations that are related to handheld ultrasound, I noted to increase access and prioritize distributing these devices in primary and rural areas, as these showed lower functionality. Improving research and training. These devices are cost effective, and it was shown that government facilities struggle with functionality. And then it would be important to have battery solutions for these handheld ultrasounds, because we did note that there are interruptions that occur at some facilities. So if we are going to implement it, we need to have rapid charging infrastructure or extra battery packs, etc. And then just to note the limitations of handheld ultrasound, it's not going to work at tertiary level facilities, because those facilities need improved level of imaging that only cart-based can deliver. Thank you. These are my acknowledgements. I'd like to thank Dr. Sue, Dr. Wiener, and Hervé Faso, who was my tutor, who helped me along with this. Thank you.
Thank you, Leonda. Congratulations, and thank you for this presentation.
Thanks.
Bobby, I see your hand is up.
Hey, thanks. Great presentation, Yolanda. I'm wondering from your both from your experience and from the data, why do you think that ultrasound is more available in rural settings than in urban ones? I thought that was a very interesting finding.
Yeah, I thought that was an interesting observation too. The only thing that I could think of is that perhaps with funding or non-governmental parties that have come to the table, that more medical devices have gone out to those rural areas. Those rural areas also have a lot of primary care facilities too, and primary care facilities did dominate in terms of number of facilities because Malawi takes a tiered approach to healthcare.
Interesting. Thank you.
Thanks.
Any other questions from the audience?
I have my hand up.
Oh, I'm sorry. I can't see you.
It's
Go ahead,
okay.
Deepa.
Surprised Bobby beat me to it, but
Sorry.
I was actually typing out Leanda and then I just decided to raise my hand. Nice presentation, really interesting work. So my question is this, has there been any discussion around solving one problem, potentially creating another? And I'm just thinking of wastage, right? Like batteries and, you know, portable devices in place of these, you know, improving the, you know, electrical grid and electrical stability and things like that. I mean, that's the first thing that comes up in my mind. I'm not an expert in this area, but I just wonder if there's been any discussion or thought about that in the process of doing your work.
I haven't necessarily thought about that, but what I have thought about is the fact that answering this question about power supply versus ultrasound readiness is inadequate as a complete answer as to whether handheld ultrasound is appropriate in low resource settings. It's going to take analysis on cost. It's going to take analysis on human resources. Training is an important component of this. And as you've mentioned, another thing to consider is the wastage and the potential other issues that could be introduced, because as mentioned, it does rely on battery packs and it doesn't have a good duration of battery packs. So it is going to need a lot of charging, and that may not work in facilities that have a lot of interruptions.
Thank you. Great presentation.
Thanks.
Any other questions from the audience?
I think there's one in the chat from Ravi.
Great. Sorry that I've lost steam. Robbie asked, were private facilities sampled?
Yes, they were. They were sampled. It included public, private, non-governmental, and Christian Health Association facilities.
Go ahead, Robbie.
Yeah, the reason why I was asking that is because of the, I was also curious about rural centers having, you know, more ultrasound machines. But from my experience in Nigeria, it's usually because of maternal and child health. You know, everybody, no matter, regardless of, you know, level of education, everybody wants to see what's inside the womb. So when someone is pregnant, so ultrasounds are actually very, very popular. So I just wondered if those numbers are being inflated by private people opening up, like, you know, ultrasound centers and so on. I just wondered. Thank you.
Thanks for that question, Robbie. It definitely is something to consider. That was the original basis of my research. I wanted to take a look at the antenatal component of things. However, the data was not working with me in that direction. But it is something that that needs to be, I think I could flesh out a little bit more in my research.
Thank you. Well, congratulations again, Luyanda. Assuming I'm not missing anything else in the chat. I think we can wrap up our session for today. And this is the end of our presentations for spring 2024. So congratulations again to all the graduates. We're very proud of you. We're excited to celebrate you at graduation. And thank you to everyone who supported them to make it to this important milestone. Congratulations and enjoy the rest of your day or night, wherever you are.
Yeah, it was so nice to see you all through the Zoom windows. And we look forward to seeing you for graduation. Bye, everybody.
Bye.